The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Hi, good day everyone. I'm Patrick Mabugat. I'm currently a third-year surgical resident. This will also be my third year teaching in Top Notch, and over the past 3 years that I've been teaching in Top Notch, I've collected different high-yield topics and points and incorporated them in this pro surgery lecture. Referencing, of course, Schwartz Principles of Surgery, Upside and Board Review, and the main handout. So this is in no way designed to replace your main handout, but only to supplement and emphasize again the very high-yield points and topics that I believe will help you answer a question or two in your upcoming board exams. So today I'm just very honored and very excited to give this lecture to you guys. So without further ado, let's start. Question number 1. The effective colloid osmotic pressure between the plasma and interstitial fluid compartments is primarily controlled by: is it A, bicarbonate, B, chloride, C, potassium, or D, protein? Correct answer for this question is letter D, protein. So your oncotic pressure refers to the pressure exerted by dissolved protein in plasma does not pass through the semi-permeable membrane. So this pressure affects your osmosis. Remember that dissolved protein in a compartment contributes to the solute concentration in that compartment. And remember that whenever there's a compartment with excess solute concentration, that's where your water goes. So water is being pulled into a compartment, again with a high solute concentration and a high protein concentration. So this is otherwise again known as your effective or colloid osmotic pressure, or otherwise known as your oncotic pressure. So your oncotic pressure is only one of the 4 major starting forces that control water transmission in your capillaries and tissues. So other 4 parts of your starting forces include your capillary hydrostatic pressure, your interstitial fluid hydrostatic pressure, the interstitial fluid osmotic pressure, and again our capillary or plasma protein osmotic or oncotic pressure. We're talking about your fluids and electrolytes. It's also again important to discuss the total body water. According to demographics, males have higher percentage total body water as compared to females. Males have 60%, while females have 50%. The reason for this is that males have higher lean body tissue, especially muscle, and it's in that lean tissue where you find your water most of the time. Females have higher adipose content, and remember, as we say, oil and water don't mix. If there's high adipose tissue, there's high oil, there's less water. Okay, so females again have 50%, that's 10% less than the average male, less total body water. Newborns are born with more lean tissue than adults, and they develop gradually to their adipose tissue as they grow older. So newborns have 80% adipose tissue. Obese and malnourished, in the same context, in the same vein that we're talking about, obese people having higher adipose tissue, having higher oil, have less water in their bodies. So the total body water is adjusted downward by 10 to 20%. While malnourished people have their total body water adjusted upward by 10%. And if you see this diagram right here, just below this one, now you can see that the total body water is divided into different compartments. You have your ICF and your ECF. I stands for intracellular fluid and E stands for extracellular fluid. The ICF makes up majority of your total body water, 40%, as compared to your extracellular fluid compartment, which is only 20%. The 20% of the ECF is further divided into your interstitial fluid, your plasma volume, your interstitial fluid making up 15%, your plasma volume making up 5% only of the total body water. Next high yield point, most common fluid disorder of surgical patients, it's your extracellular volume deficit. The reason why the extracellular compartment is more easily affected than the intracellular compartment is that because the cells always make sure that they maintain their homeostasis. Thus, the first to compromise is the one extracellularly. So again, it's the extracellular volume which is affected first, affected more commonly, especially in patients who are surgical. Next, most common cause of volume deficit in surgical patients, it's the loss of GI fluids, either by vomiting, diarrhea, nasogastric suctioning, or other types of endocutaneous fistulas. Next, most common cause of volume overload is usually iatrogenic. So when the physician overhydrates, over-administers a certain type of fluid in the patient, it's usually the most common cause of volume overload. And what's its earliest sign? It's weight gain. Because again, the total body water contributes significantly to the total body weight. Now, when we're talking about how fluids are lost from our body, it's not only important to memorize or identify the sensible losses. When I say sensible, these are losses that can be measured directly. It's also important to take note of your insensible losses. So we have two organ systems which are usually part of your insensible losses. It's the respiratory and the skin. Lungs make up 75%, while the skin makes up 25%. Again, the lungs and the skin, lungs 75, skin 25. When we're talking about fluids, it's also important to talk about electrolytes. Again, our major cations and anions. For the extracellular fluid, it's your sodium, which is the most important cation. Intracellularly, it's the potassium, which is the most important or most abundant cation. Extracellularly, for the anions, we have chloride. Intracellularly, we have your phosphate. It's also important when we're talking about fluids and electrolytes and how we can apply it and how we can hydrate our patients. Now we have different solutions, we have different isotonic fluids that we administer to our patient. So hypertonic fluids or hypotonic fluids. However, I think what's important is we understand these two, your lactated ringers, your normal saline solution or your NSS. So between the two, it's your LR which more closely resembles your human plasma. Okay? While your ECF has sodium of 142, LR has 130, chloride 103, LR has 109, potassium 4, LR also has 4, or carbonate 27, your LR has 28, calcium 5, your LR has 3, no magnesium, but the milliosmolarity is always somewhat the same. ECF, it's 280 to 310. Your LR is more from the hypotonic side, 273, but it's still near the 280. Your NSS, your 0.9% plain NSS, only has normal saline. Saline means sodium chloride, 154 sodium, and 154 chloride with a milliosmolarity of 308. 154 plus 154, that's 308, so you don't get fused. Your NSS as compared to your LR is slightly a bit more relatively hypertonic. That's why NSS is actually preferred in neurotrauma, in which we want to pull water away from the cerebral compartment back to the vasculature. That's as compared to your LR. Next, crystalloid preparation that most commonly resembles the electrolyte concentration of plasma. So this preparation was actually developed to, again, supply the same electrolytes that your LR is actually giving your body, but negating the effect of its changes on the acid-base balance. If you can remember, LR NSS, which causes acidosis, which causes alkalosis. It's your LR, which causes your alkalosis. It's your NSS, which causes your acidosis. Again, even if it's called lactated ringers, the lactate there, even if you get easily confused thinking it's lactic acid, it's going to become acidotic. Your LR actually becomes alkalotic in the body because the lactate there is converted into your bicarbonate, and bicarbonate is a base. So lactated ringers can cause alkalosis, okay, not acidosis. It's your NSS which changes up, which interferes with the sodium and hydrogen reabsorption, which actually causes your acidosis because the hydrogen ions are preferentially preserved in the body if you have an excess of sodium in it. So again, back to the question, what crystalloid preparation most closely resembles the electrolyte concentration of plasma? And this is your plasma light. Next question, which of the following is the most common intrinsic platelet defect? Is it A, thrombocythemia, B, Bernard-Solier syndrome, C, cyclooxygenase deficiency, or D, storage pool disease? So the correct answer is letter D, storage pool disease. Storage pool disease is a problem of your platelets which involves the loss of your dense granules and alpha granules. Without going too deep, your dense granules and your alpha granules both help in platelet adhesion, aggregation, and activation. Between the two, the most prevalent storage pool disease is your dense granule deficiency. It's a dense granule rather than the alpha granule, which is more commonly affected. Now for our pearls, what's the most common abnormality of hemostasis that results in bleeding in the surgical patient? It's your thrombocytopenia and platelet dysfunction. So again, most common abnormality of hemostasis in the surgical patients, it's basically just platelets. Quantitatively, if you have less platelets, you call that thrombocytopenia. If you have normal platelets but they're not functioning really great, you have your platelet dysfunction. So again, thrombocytopenia and platelet dysfunction. Next, most common congenital bleeding disorder, it's your von Willebrand's disease. So your von Willebrand's disease is either a qualitative or a quantitative defect in your von Willebrand's factor. So von Willebrand's factor are actually just nets flowing around in your bloodstream. When your body has an injury, that injury stimulates and attracts your glycoprotein 1b95, that's your GP1b95. And the GP1b95 attaches to your von Willebrand factor. Again, blood vessel, there's an injury here, GP1b95 goes out, then you have your VWF floating in plasma. What happens, both of which will act like a net. And a platelet comes by, it's going to stick to that GP1b95 and VWF combination, and it's gonna just adhere and start aggregating and then start activating. The GP1b95 to VWF, you call it the platelet adhesion phase. If you have a deficiency of your VWF, you call that the von Willebrand disease. If you have a deficiency of your GP1b95, you call that your Bernard-Solier syndrome. Now, just a little bit of a seg, GP1b95, VWF, that's adhesion. When two or more platelets attach to each other, you now call that aggregation, and it's mediated by another glycoprotein, your GP2B3A. A defect of your GP2B3A, glycoprotein 2B3A, is otherwise known as your Glanzmann's thrombasthenia. Next, what's the most common acquired coagulation inhibitor syndrome? It's your antiphospholipid syndrome. And a classic example of this, common example of secondary antiphospholipid syndrome, which causes recurrent thrombosis, pregnancy loss, is your lupus anticoagulant. So SLE actually is a common cause of your antiphospholipid syndrome. Next, most frequent coagulation factor deficiencies is your factor 8, hemophilia A, factor 9, hemophilia B, and factor 11. 8, 9, and 11. When we're talking about coagulation diseases, again, I think it's important in surgery to understand your DIC, otherwise known as consumptive coagulopathy. So this is due to an inciting etiology, whether trauma or infection, associated with thrombocytopenia, prolongation of prothrombin time, a low fibrinogen levels, and elevated fibrin markers, your FDPs, D-dimer, soluble fibrin monomers. So the reason for your DIC is that when you have an injury, when you have an infection, there's excessive introduction of thromboplastin, otherwise known as your tissue factor, in the circulation. So when you have excess tissue factor, it's just going to stimulate coagulation, activate your platelets, As a result, your platelets are consumed, thrombocytopenia, pro time is prolonged because the extrinsic factor pathway is affected and consumed, low fibrinogen level because fibrinogen is converted to fibrin, and elevated fibrin markers. Again, these are just basically your byproducts of your fibrin. Okay. So your DIC at the onset is actually a clotting problem. So your body clots too much systemically. However, as the disease progresses, your DIC, even though if you think coagulation is just clotting, your DIC actually predisposes to bleeding later on. Because you just know its other name, it's consumptive coagulopathy. What happens is that these coagulation factors, they're gonna get consumed. They get consumed after initial bouts of clotting. Eventually, your body is gonna bleed because it's losing clotting factors, it's losing platelets. So that's your DIC. Again, due to excessive thromboplastin activation in the circulation. So we have a syndrome associated with large hemangiomas, thrombocytopenia, anemia, and DIC. So we have large hemangiomas, then we have DIC, we call that your Kasabach-Merritt syndrome. Hemangiomas associated with DIC, again, it's the Kasabach-Merritt syndrome. For transfusion pearls, what's the most common indication for transfusion in surgical patients? It's the replenishment of blood volume. So if you want volume, you give whole blood. If you want to reestablish the oxygen carrying capacity of blood, you give packed RBCs. If you want to replace your plasma, you give FFP. If you want to replace specific coagulation factors, you give specific coagulation factors. If you want to give fibrinogen, you give fibrinogen. However, if there's no fibrinogen concentrated, there's no concentrated fibrinogen, you can give your cryoprecipitate. What's the most common adverse transfusion reaction? It's your febrile non-hemolytic transfusion reaction. So your febrile non-hemolytic transfusion reaction, FNHTR, non-hemolytic, there's no lysis of your RBCs involved. It's actually due to the cytokines carried by your platelets from the donor which are activated in the recipient. So the cytokines, as we know some of the cytokines, we have IL-1, which predisposes to fever. When they activate, they elicit, again, somehow an inflammatory response in the recipient. So febrile non-hemolytic transfusion reaction. So what's the leading cause of transfusion-related deaths? This is your transfusion-related acute lung injury or your TRALI. Again, most common adverse transfusion reaction is your FNHTR. Leading cause of transfusion-related deaths, you have your TRALI. Next, most common cause of bacterial contamination of blood. This is your gram-negative organisms. So if something infects or contaminates blood, it's usually gram-negative organisms. And the species most commonly implicated in the transmission of malaria in blood products is your Plasmodium malariae. Plasmodium malariae. Next, which of the following is not a sign of tension pneumothorax? Is it A, tracheal deviation, B, decreased breath sounds, C, respiratory distress with hypertension, or D, distended neck veins? So the correct answer for this question is letter C, not a sign, respiratory distress with hypertension. So tracheal deviation, of course, when you have air here, it's going to push the lung to the other side, pushing the trachea to the other side. Decreased breath sounds because air does not serve as a good conductor of sounds. And distended neck veins because when there's air here, lungs push to the other side, trachea push to the other side, the mediastinum twists upon itself, impinging upon the vena cava and the arteries. The vena cava, when impinged, is going to backflow and cause distended neck veins. Letter C is incorrect because it's not supposed to be hypertension, but instead it's supposed to be hypotension. So respiratory distress with hypotension in combination with any of the following physical signs, again, tracheal deviation, lack of decreased breath sounds, subcutaneous emphysema in a patient who recently underwent trauma, gives you high index of suspicion of tension pneumothorax. But Again, just emphasizing the most important sign that qualifies pneumothorax as being intention is hypotension. It's a decreased BP which qualifies pneumothorax as intention. So if you identify signs of tension pneumothorax and you have a high index of suspicion, you don't need to wait anymore for a chest X-ray. You can immediately proceed to an intervention which is life-saving, what we call your immediate needle thoracostomy or needle decompression in the 4th or 5th ICS anterior axillary line. Now previously, classically, they've used the 2nd ICS mid-clavicular line. Again, if the question the board exam has the following choices and you don't see 4th or 5th ICS anterior axillary line, you can still use the classic 2nd ICS mid-clavicular line. Again, if there's no 4th or 5th ICS AAL on the choices. However, if you see more recent guidelines, especially also you can see this in Schwartz, instead of using the 2nd ICS mid-clavicular line, we've been using the 4th or 5th ICS anterior axillary line. Again, the keyword there is 4th or 5th anterior axillary line. Why? Because when we do CTT, which is the more definitive procedure, we do it after needle decompression, we do it if the patient has pneumothorax but stable. If we see hemothorax, we do chest tube thoracostomy or CTT, and we do it in the 4th or 5th ICS still, but mid-axillary line. Again, needle decompression, 4th or 5th ICS anterior axillary line. CTT, we do it 4th or 5th ICS mid-axillary line. These are different types of pneumothorax. You have your closed without obvious injury. It's most probably a tear in the lung parenchyma. So what happens is that the lungs are pushed to the other side. And you have your open pneumothorax. If it's an open pneumothorax, it's sometimes a sucking chest wound where the injury actually acts as a ball valve effect, only allowing air to go inside and not outside. So what we do is we apply a 3-sided tape, or sometimes in the movies they use a credit card to cover the injury and to act as a valve, preventing air from going in but allowing air to go out. Next, flail chest. So flail chest occurs when there's 3 or more contiguous ribs affected in at least 2 locations. So you have 1, 2, 3 ribs. These 3 contiguous ribs that have injuries at 2 points in each rib. Okay, that's your flail chest. So the flail chest actually affects your lung parenchyma because of the paradoxical movement of that flail segment. And also, the most important part there is if there's paradoxical movement, if there's already an injury there, there's almost always a pulmonary contusion. It's a pulmonary contusion which actually predisposes the patient to respiratory distress because of a VQ mismatch, decreased compliance, increased shunt fraction. So again, in a flail chest, it's again 3 ribs fractured in 2 or more locations. These are contiguous with an underlying pulmonary contusion. It's a pulmonary contusion which predisposes the patient to desaturation. Okay. A flail chest with a pulmonary contusion is not called a flail chest per se, but according to Schwartz, we just call that a flail segment. The treatment for a flail chest is preemptive intubation and mechanical ventilation. So you intubate the patient early on and you ventilate the patient using especially your PEEP, provide positive pressures to the airways. Because in pulmonary contusion, the airways, the air sacs there are not expanding as much as you'd like them. So you need to apply positive pressure to allow them to open, to allow them to heal over time. So that's preemptive intubation and mechanical ventilation, along with pain control, incentive spirometry, and allowing the patient to just breathe deeply. Those are managements for your flail chest and your pulmonary contusion. Next, we have your other trauma pearls. Just remember your primary and secondary survey. For primary survey, you have airway, breathing, circulation, disability, and exposure. We have the mnemonic A, B, C, D, E. Again, it's airway, breathing, circulation, disability, and exposure. For airway, it's not just airway. We try to access or ensure good airway in the patient. You need also to protect the cervical spine, especially if you're trying to manipulate it to allow you to enter the airway. Again, that's airway and cervical spine, breathing, circulation, disability, and exposure. Or more recently, just a little bit of trivia, they've already included an X before ABCDE. That's basically XABCDE. The X there is exsanguination. You need to prevent the patient from bleeding out first before making sure or assessing the different parts of your primary survey. So these 5 are not assessed one after the other. They're assessed actually simultaneously. After the primary survey, you do initial resuscitation. You proceed to secondary survey, and your secondary survey is composed of your ample. So please memorize this. You have your allergies for letter A, medications for letter M, pregnancy and past medical history for your P, last meal for your L, events and environment for your letter E. Again, primary is ABCDE, secondary survey is ample. It's allergies, medications, past medical history, pregnancy, last meal, and events and environment surrounding the injury. Next, what's the most common cause of death for those 1 to 44 years old? You guessed it, it's trauma. Trauma is the most common cause of death, age 1 to 44. The most common indication for intubation in a patient who recently underwent trauma is an altered mental status. So the most common cause of upper airway obstruction in an unconscious patient, this is your tongue. Okay? So it's not peanut, it's not meat, it's the tongue. Okay? So they consider it as an object which causes your obstruction. Then if the patient has altered mental status, they're prone to aspiration, not only aspiration, but they can't protect their airway from being occluded by the tongue. So that's where you intubate the patient already. Next, what's the most common facial fracture? It involves your mandible. The most commonly injured abdominal organ in blunt abdominal trauma, because of its sheer size, it's your liver. What's the initial evaluation for patients with blunt abdominal trauma? It's your FAST, which stands for Focused Assessment with Sonography for Trauma. So using an ultrasound, you identify these 4 key quadrants or 4 key areas, and you try to identify free fluid. In a patient with trauma, you almost always assume this as hemoperitoneum. So these are the hepatorenal recess, the perisplenic view, the subxiphoid pericardial window, and the suprapubic window. To the right side, you have your hepatorenal recess. Left side, you have the perisplenic view. In the middle up, you have your pericardial window, which is subxiphoid. In the middle down, you have your suprapubic window. So again, you try to identify free fluid. So FAST has largely supplanted the more classic and the earlier DPL, because in DPL or diagnostic peritoneal lavage, as its name says, you do lavage. It's more invasive because you have to access the abdomen and give fluid or try to aspirate fluid from it. If you see blood, it's positive already. However, if there's none, you try to infuse a liter of saline and you try to get the fluid back and run it through hematology, a cell count, and chemistry. So the parameters for DPL are high yield, even though DPL is less likely used more nowadays. So for the board exams, I think what's important is you just understand and memorize the parameters. So we have 5 parameters. You have your RBC, WBC, amylase, alkaline phosphatase, and bilirubin. Again, that's RBC, WBC, amylase, alkaline phosphatase, and bilirubin. Okay, so these 5 actually has more or less the same criteria for abdominal and thoracoabdominal stab. Once again, it's abdomen only versus thorax and abdomen. Main difference is in the RBC, while abdominal trauma has a threshold of 100,000 per ml for a positive DPL. The thoracoabdominal stab wounds has a threshold lower at 10,000 per ml, because again, that's the thorax and abdomen affected, so they have lower thresholds as compared to abdominal trauma, which is 100,000 per ml. Now WBC, that's 500, amylase, that's 19, ALP, that's 2, bilirubin, it's 0.1. So again, this requires a bit of brute memorization, but I hope you try to write this down and try to memorize this a few days or a few hours prior to the board exam so that you don't get confused. Again, RBCs more than 100 for abdomen, more than 10,000 for thoraco-abdominal stab wounds, white blood cells more than 500, amylase more than 19, ALP more than 2, and bilirubin more than 0.01. So again, before they've used DPL, however, it's very invasive, so now we've used FAST, a positive FAST, in the setting of hemodynamic instability with injuries to the abdomen, with signs of peritonitis, would incline the surgeon to bring the patient to the OR immediately, not do further workup. However, if you have a positive FAST without the signs as previously mentioned, or a negative FAST but still equivocal, as a time you can still proceed to abdominal CT scan. Other trauma bros, you have our triads for trauma. Beck triad of pericardial tamponade, you have your hypotension, muffled heart sounds, and neck vein distension. Again, Beck triad of pericardial tamponade, hypotension, muffled heart sounds, neck vein distension. Okay. So pericardial tamponade may occur when the fluid is up to 100 ml in the pericardial space. However, just doing intervention, removing as little as 10 cc can greatly improve the hemodynamic status of the patient. So what intervention you give is your pericardial drain or pericardiocentesis. That's hypotension, muffled heart sounds, and neck vein distension. For the other triads, we have the Bergman triad of fat emboli. You have your changes in mental status, petechiae over the thorax, and dyspnea. Again, changes in mental status, petechiae over the thorax, and dyspnea. The Bergman triad of fat emboli, you should consider this in patients with large fractures, especially femoral or pelvic fractures, again with the aforementioned signs. For the lethal triad of the bloody vicious cycle, which sometimes calls the Virchow's triad, we have your post-injury coagulopathy, core hyperthermia, and metabolic acidosis. So coagulopathy, hypothermia, and acidosis. Coagulopathy, hypothermia, acidosis. So these form a bloody vicious cycle. They cycle back to themselves, causing each other to aggravate and to worsen the condition of the patient when one of them is present. So these three, if present, are actually indications for damage control surgery. So damage control surgery, or DCS, was actually developed to just limit GI spillage and to prevent exsanguination or bleeding in the patient. So what you do is just you open up, repair what needs to be repaired, close the patient, stabilize the patient first, and have a second look later on. So that's your damage control surgery. When indications are lethal triad, bloody vicious cycles, a Virchow's triad, coagulopathy, hyperthermia, and acidosis. Next, shock caused by a large tension pneumothorax is categorized as A. Trauma shock, B. Vasodilatory shock, C. Cardiogenic shock, or D. Obstructive shock. Okay, again, as we've discussed, large tension pneumothorax, what happens that the mediastinum is shifted, it rotates. What happens that the inferior vena cava and the superior vena cava are impinged, so they can't return venous blood back to the right atrium and the right ventricle. So what happens is the preload goes down, then the mediastinum twists, the aorta cannot push blood out. So if vein cannot go in by the vena cava and cannot go out via the aorta, there is an obstruction. So actually, your tension pneumothorax is a type of obstructive shock. So what is shock? Shock is failure to meet the metabolic needs of the cell and the consequences that ensue from these changes. So we have 6 types of shock. The most common is hypovolemic shock, followed by cardiogenic, septic, neurogenic, traumatic, which may be a combination of the previously mentioned types of shock, and obstructive shock. Again, hypovolemic, cardiogenic, septic, neurogenic, traumatic, and obstructive. So this table from Schwartz, you have at least 2 or 3 tables in Schwartz, which discuss the different types of shock, but I prefer this one because it has an in-depth bird's eye view of how the different types of shock contribute to different hemodynamic parameters So they've just listed four. For hypovolemic shock, a decreased blood volume is gonna depress the cardiac index, it's gonna depress the amount of blood that is being pushed out of your heart. In response, your body is gonna try to constrict its peripheral vasculature to allow blood to go back to the heart and perfuse the more important organs. The SVR, the systemic vascular resistance, increases, and your capacitance, which is basically the opposite of your SVR, decreases. Okay. For septic shock, the problem there is due to toxins found in your bacteria, especially the gram-negative ones, which release your endotoxins, more specifically your inner lipid A, which causes peripheral vasodilation. So if there's vasodilation, blood stays at the peripheral vasculature longer and than expected. So what happens is that your heart is going to try to pump more blood actually. So the cardiac index actually increases. But the SVR is actually decreased, the resistance is decreased because again of the toxins. So it's caused by the toxins. And the capacitance is basically, again, as we said, opposite of that, actually increases. For cardiogenic shock, the problem there is in the heart, it's cardiogenic, so cardiac index is decreased. The heart is not pumping blood as much as it'd like to because there's a problem with the heart, a myocardial infarction perhaps. As a result, your body will try to recognize that the heart is not pumping, it's going to constrict its peripheral vasculature. However, it's still usually not effective because the heart, again, is the main pumping organ, it's the main pump of the body. Then we have the neurogenic shock, in which the vascular resistance again drops down. As a result, blood pools through the extremities because there's no neural stimulation for your vasculature to constrict. As a result, your heart pumps blood more, same as in your septic shock, but it's just a compensatory mechanism. Next, we have the different stages of hemorrhagic shock. We have class 1, 2, 3, and 4. Your tachycardia and tachypnea is found in at least one type of shock. That's class 2 with blood loss of 750 to 1500 or 15 to 30%. Hypotension, decreased urine output, at least one type of shock. That's class 3, blood loss of 1500 to 30 to 40%. Okay, so we have 4 classes of shock. Again, we can memorize the parameters associated with each class of shock by using the tennis system. So if you're a tennis player, you've already got this in check. So for class 1, that's just for the tennis system, 1, 2, 3, 4. 1 is 15, so class 1, 15. 2 is 30, okay. 3 is 40, and 4 is game, okay. So for class 1, we're talking about percentages here. That's 0 to 15%. 1, 15, that's 0 to 15. Class 2, again, we're talking percentages. Class 2 is, but 2 is 2 is 30, that's 15 to 30. Class 3 is 40, that's 30 to 40. And class 4 is 40, that's more than 40. Again, 0 to 15, 15 to 30, 30 to 40, more than 40. Okay? So how do we memorize the volumes? It's actually easier. After you memorize the tennis system of 0 to 15, 15 to 30, 30 to 40, more than 40, you just divide it into 2 by volume. So for 15, you divide it into 2, you get 7.5. Basically, just multiply it by 100, so you get 750 ml. So class 1, that's 0 to 15, 15 divided by 2, you get 750. Okay. Next, class 2, that's 30, it's 15 to 30. 30 divided by 2, you get 1500. But 30 divided by 2, that's 15. Multiplied by 100, that's 1500. So for class 2, that's 15 to 30, or 750 to 1500. Class 3, that's 30 to 40. 40 divided by 2, you get 2000. So 20 divided by 100, that's 2000. So that's 30, 40, 1500 to 2000. Class 4, that's more than 40, divided by 2, that's more than 2,000. So again, that's an easy way of memorizing the different types of shocks. I hope you get it. So for the signs symptoms, you just need to identify that tachycardia and tachypnea first occurs in a class 2 shock. Okay? Increased heart rate, increased respiratory rate, that's class 2 shock. Hypotension and decreased urine output is at least a class 3 shock. When you have hypotension decreasing BP already, you've lost at least 1,500 or 30% of blood if we want to derive it from the percentages. That's again a class 3 shock. Decreased urine output, that's less than 0.5 cc per kilogram per hour. In adults and children, it's less than 1 cc per kilogram per hour. And for infants and newborns, it's 1.5 to 2 cc per kilogram per hour. Next, for pearls, what's the most frequently encountered form of vasodilatory shock? It's your septic shock. Next, most common cause of death in patients hospitalized with acute myocardial infarction, that's your cardiogenic shock. Again, myocardial infarction affecting the heart, that's your cardiogenic shock. Next, primary purpose of using pneumatic anti-shock garments, that's to increase venous return to the right atrium. That's your pneumatic anti-shock garments. When we say pneumatic anti-shock garments, it means that they're using air to compress your peripheral vasculature. So basically, it's like a garment which compresses your vasculature and returns blood back artificially back to the heart. Okay. Primary purpose of using pneumatic anti-shock garments, again, is to increase venous return to the right atrium. So you don't forget that, because it sometimes sounds like a trivia question that actually has popped out in 2 board exams previously. Most common cause of obstructive shock in trauma patients, it's tension pneumothorax, as we previously discussed. Next, what is not a component of the systemic inflammatory response? Is it letter A, temperature, B, white blood cell count, C, blood pressure, or D, is it your heart rate? Okay. So not a component of the systemic inflammatory response, you have temperature, white blood cell count, blood pressure, heart rate. So the correct answer for this one is blood pressure. Because as we've discussed in a refresher lecture, walang BP si sir. So no BP for sirs. So what are the parameters for SIRS? You actually need 2 only out of the 4 to fulfill the criteria for a systemic inflammatory response syndrome. It's temperature, heart rate, RR, and WBCs. Again, walang BP si sir. Temperature more than 38 or less than 36, heart rate more than 90, RR more than 20, or PCO2 less than 32, because again, PCO2 or the content of carbon dioxide in your arteries is actually affected by respiratory rate. Because when you expire, PCO2 is getting pushed out. So if you're breathing faster than normal, your PCO2 is actually going to become decreased because more carbon dioxide are being pushed outside into the environment. Or mechanical ventilation. WBCs, it's either going to be more than 12,000. There's leukocyte tubulosis, a compensatory response to increase your inflammation and to allow your immune system to work better, or less than 4,000. Why less than? Why decreased? If we're talking about inflammation, if it happens too much, overloading your body, WBCs are going to get consumed, your immune system organs are going to get exhausted. As a result, your WBCs drop down. So it's either more than 12,000 or less than 4,000. Or more than 10% bands, or what we call a shift to the left, to the more immature precursors of your neutrophils. Now, the SIRS criteria is actually the classic and the older criteria in defining the different types of infection, of sepsis. We've more recently moved to your SOFA, your Sepsis 3 guidelines, which again use your SOFA criteria. Your SOFA criteria is actually a bit cumbersome because it requires the patient to undergo laboratories. However, in the field, just to triage and prognosticate which patients are at risk for deterioration from sepsis and which patients to admit, we have again the Q-SOFA criteria with our mnemonic hat in the SOFA. Okay, this RR more than 22, altered sensorium less than 14, systolic blood pressure of less than 100. So what is HAT there? HAT there is HAT. H is hypotension less than 100. A is altered sensorium less than 14. And T there is RR, tachypnea, more than 22. Okay, that's HAT on a SOFA. Q-SOFA criteria. In SIRS, it's 20. In Q-SOFA, it's 22. So just you don't get confused. Next, a patient in septic shock remains hypotensive despite adequate fluid resuscitation and initiation of norepinephrine. What is then given to patients with hypotension refractory to norepinephrine? So if you give your first line of inotropes in patients with septic shock, according to Surviving Sepsis Campaign or sepsis guidelines, what you give next is actually your arginine vasopressin, otherwise known as your ADH or your antidiuretic hormone, which is actually a pretty potent vasoconstrictor. So what is septic shock? Septic shock is sepsis plus cardiovascular collapse. Again, sepsis plus cardiovascular collapse. Just to give you again a review, we have a spectrum of terms, infection and sepsis. So again, this is again the older terms. We've since then moved away from these definitions to more objective definitions, again by your sepsis 3, your SOFA criteria. Right. So for infection, this is basically just microbes there, an identifiable source of microbial insult with host response, that's your infection. SIRS is 2 or more of the following criteria, temperature, heart rate, RR, WBC, but SIRS is just a response by the body. So it does not specify if it's either traumatic or infectious in nature. Sepsis is SIRS plus an infection. So again, sepsis is SIRS, it's 2 out of 4 of the previously described criteria, plus an infection. While severe sepsis is sepsis plus organ dysfunction, whether neurologic, renal, respiratory, among others. However, if it's sepsis, which causes hypotension or cardiovascular collapse, which requires vasopressor support, we've already been using inotropes in this patient, and the patient responds. This is what we call now your septic shock. Septic shock. Okay, according to the sepsis guidelines, what's the initial resuscitation rate in adults with hypotension? It's crystalloids 30 cc per kg in the first 3 hours. You give crystalloids 30 cc per kg in the first 3 hours. So what are the parameters that you need to identify if you've done adequate hydration in a patient or done adequate resuscitation in a patient? So you need to identify your BP by way of your mean arterial pressure, your urine output along with other vital signs that you might identify in the patient, along with adjuncts such as your arterial blood gases and your lactate levels. For sepsis, we have a target MAP or mean arterial pressure of 65 millimeters mercury. If you don't meet that, we need to give hydration again or you can proceed to vasopressors. First line vasopressor, we have your norepinephrine. The patients who are refractory to norepinephrine can give arginine vasopressin. In patients with long-standing inflammation or infection, these patients do not respond to hydration or any type of inotropes at all. This may be due to a relative steroid deficiency, which we call your CIRCI, C-I-R-C-I, and this usually occurs because the adrenal cortex has exhausted its production of your steroids, which actually help in metabolism and also affects your vasculature. So what happens that we need to give these patients your steroids. We need to supplement them with steroids, especially again in long-standing or severe infection or inflammation in the body. Other pearls, upper blood glucose target in sepsis, according to your Surviving Sepsis Campaign, it's 180 milligrams per DL. Usually it goes over this if the patient is in sepsis because your body is trying to compensate by releasing its stress hormone, which is practically your cortisol. However, an excess of cortisol and excess of your sugar, the body is actually gonna impede in the immune response, impede in the recovery period. Thus, you need to have a tight glucose control less than 180 milligrams per DL. Next, what's the indication for RBC transfusion in sepsis? So, more or less is the same. When we want to transfuse, we have the trigger point of 7 milligrams per DL. Okay. Hemoglobin less than 7 milligrams per DL, that's when you transfuse in sepsis or basically in most other causes or most other indications for surgery. Next, target initial tidal volume and plateau pressure in patients with acute lung injury and sepsis. That's 6 ml per kilogram body weight. I think it's the tidal volume, 6 ml per kilogram body weight. For the plateau pressure, you need to maintain it less than 30 cm water plateau pressure. More than 6 tidal volume, less than 30 plateau pressure. Next question. During a laparoscopic appendectomy, a large bowel injury was caused during trocar placement with spillage of bowel contents into the abdomen. What class of surgical wound is this? Is it A, class 1 clean, B, class 2 clean contaminated, C, class 3 contaminated, or class 4 dirty? Okay. Just a review. Class 1, you don't enter anything. Class 2, you enter the GU, GI, respiratory tract, but there's no spillage or contamination. Class 3, you enter, but now with spillage and contamination. Class 4 is when it's already infected, it's necrotizing, or there's severe already contamination. So, for this one, laparoscopic appendectomy, take note, it's very important that you enter the trocar carefully, especially if it's a bit sharp. And when you enter the trocar and when you scope after, you need to scan the field and to assess that you've not injured other parts of other organs in the bowel, in the abdomen. So, however, if you perforated a bowel, so this is already considered entry with significant contamination, so the spillage. So this is again a class 3 contaminated. So surgical wounds are classified based on the presumed magnitude of bacterial load at the time of injury. So again, you have 4 classes. Just a review. Class 1, there's no entry. Examples, hernia, breast surgery. Class 2, you have clean contaminated. You have entry of GU, GI, respiratory tract, but with no spillage. Examples may include your cholecystectomy and elective GI surgery. There's also a subgroup under your class 2 which only pertains to your colorectal surgery, which is a higher percentage of infection as compared to its other counterparts in the class 2 surgical wounds. You have your class 3 contaminated, which again, there's injury, but there's already significant contamination and spillage, introduction of bacteria due to major breaks of sterile technique or inflammation, such as in penetrating abdominal trauma, large tissue injury, or enterotomy during bowel obstruction. Second, class 3 contaminated. For class 4, there's already overt infections such as perforated diverticulitis and necrotizing soft tissue infection. So again, I think you just need to understand and to try to give examples for you to memorize the surgical wounds. The management of surgical wounds based on class. For class 1 and 2, you close the wound primarily. That's primary intention. You suture it. You approximate the ends of the skin that you have separated. However, for class 3 and class 4 wounds, especially if you have very dirty injuries, if you have dog bites, you can do secondary intention. But for dog bites, if the wound actually secondary intention is you don't approximate, you allow it to granulate from the bottom up, allow it to epithelialize later on. If, especially in animal bites, if the wound has adequately healed by secondary intention, the wound bed is not infected, you can proceed to tertiary intention, which is basically a combination of secondary and primary. So you allow it to heal open, you allow it to granulate. When the wound bed is good, you try to close it primarily. That's your tertiary intention. Next, what refers to administration of an antimicrobial agent or agents prior to initiation of certain specific types of surgical procedures in order to reduce the number of microbes that enter the tissue or body cavity. So when you want to give antibiotics in anticipation of possible infection or contamination, but you've not actually encountered this infection or contamination already, So you call this prophylaxis. Prophylaxis means you need to prepare the patient for possible microbial contamination. If you have the 4 general principles of prophylaxis as highlighted in Schwartz. Number 1, you select an agent with activity against organisms commonly found at the site of surgery. So if you think that the most commonly found organisms that are gram-positive, you need to target the gram-positive organisms with antibiotics that actually have gram-positive activity. If there's gram-negative there, you give gram-negative targeting antibiotics. Next, you need to administer the initial dose of antibiotics within 30 minutes prior to incision. So we need to administer the initial dose of antibiotics 30 minutes or sometimes 1 hour prior to incision. So 30 minutes sometimes or 1 hour. Next, we need to reduce antibiotic during long operations based upon the half-life of the agent to ensure adequate tissue levels. So if you have, for example, Versifasolin, which have a half-life of 2 hours, and you've already gone past 2 hours, so usually reduce 1 to 2 hours past the half-life. So what you do is you reduce it at the 3rd or 4th hour. Next, you need to limit the antibiotic regimen to no more than 24 hours after surgery for routine prophylaxis. So no more than 24 hours. Next, what refers to the use of antimicrobial agents when the risk of surgical infection is high, based on the underlying disease process, such as ruptured appendicitis, or when significant contamination during surgery has occurred, such as inadequate bowel preparation or considerable spillage of colon contents. So when there's already contamination or the risk is very high and you want to give antibiotics already in this patient, from prophylaxis, you can bridge to empiric therapy intraoperatively. So again, this is called your empiric therapy. Now, another type of antibiotic administration which you already have targeted or definitive agents already, and you've already known which antibiotics these agents are sensitive to, is your definitive or targeted therapy. Next, a patient with spontaneous eye opening who is confused and localizes pain has a Glasgow Coma score of, is it A, 9, B, 11, C, 13, or D, 15. Again, a patient with spontaneous eye opening who is confused and localizes pain has a Glasgow Coma score of, the correct answer here is letter C, 13. So for Glasgow Coma score, you have 3 parameters there. You have I, response, your V, verbal response, your M, your motor response. It's EVM. So the lowest score that you can get out of the 3, for each one of them, you can get the lowest score of 1. For the 3 of them, you can get the lowest score, GCS score, of 3. Okay. For I, the high score there is 4. For V, the high score there is 5. For M, the high score there is 6. So E4, V5, M6, that's GCS 15. Okay. So for this patient, spontaneous eye opening is E4. Confused, that's V4. Localized pain, that's M5. So 4 plus 4 plus 5, you get a GCS score of 13. So your Glasgow Coma score is again calculated by adding the best motor response, best verbal response, and the best eye response. Scores range from 3, the lowest, to 15, normal. Scores of 13 to 15 indicate mild head injury, 9 to 12, moderate injury, and less than or equal to 8, your severe injury. Okay. When you have already a GCS score of less than 8, as we previously discussed, altered sensorium is actually an indication for preemptive intubation. GCS score less than 8 is already an indication for preemptive intubation. As they say, GCS score less than 8, need to intubate. So Glasgow Coma score is quantifiable determination of neurologic function that's useful for triage, treatment, and prognosis. So we have, again, your motor response, your verbal output, your eye opening. Just to review, your eye opening lowest score is 1, high score is 4. 1 is there's no response, there's no eye opening. 2 is to pressure. Previously it was to pain, but now it's more to pressure. We've gone away with sternal rub. We've now incorporated a pinch in the nails, pinch in the trapezius, or supraorbital stimulation. 3 is to voice, 4 is spontaneous. That's eye-opening. For verbal output, lowest score is 1, high score is 5. 1, there's no verbal output. 2, there's sounds. 3, there's words. 4 and 5, there's sentences, but 4 is confused. 5 is oriented, so just don't get confused. Then 1, there's no response. 2, there's sounds. 3, there's words. 4 and 5, there's sentences. 4 is confused. 5 is oriented. For motor response, again, lowest score is 1, high score is 6. For 1, there's no motor response. 2, there's decerebrate or extensor posturing. 3 is decorticate or flexor posturing. 4, with loss from pain. 5, localizes pain. Next, for head injuries, we have different types of injuries to brain parenchyma and surrounding vasculature. We have our epidural, subdural, contusion hematomas, and also have our diffuse axonal injuries, or we also have your subarachnoid hemorrhage. But for board exam purposes, I think what they usually ask are the differences between your subdural and the epidural hematomas. So for subdural, you have your bridging veins and crescent shape. For epidural, you have your middle meningeal artery and your lentiform shape hematomas. So the defining point there is their location in relation to the dura. If it's above the dura, you call that an epidural. If it's below the dura, you call that a subdural hematoma. Right? So above the dura, you have bone. Below the dura, you have brain tissue. So dura, above you have bone. If you have a hematoma there, remember the dura is intensively attaches to your bone. It's very attached to your bone. So when you have a hematoma there, the hematoma should be coming from a vessel that is strong enough to release that attachment of the dura from the bone, right? So what usually can cause this between the two, artery and vein, is an artery with high enough pressure to cause a hematoma. And remember, because there's attachments of the dura to the bone, remember it's very attached there. If you have a hematoma, it forms from the center going outside because it's trying to release the other attachments. So as a result, it's going to form a lentiform shaped hematoma, a lens-form hematoma, as compared to your subdural. For subdural, again, because you have your dura there and you have your brain tissue below. So remember that the vessels there that are attached from the dura to the brain tissue, these are what you call your bridging vessels, and they're very friable, right? So if they're very friable and they're attached this way to the brain tissue, every time your brain shifts, rocks back and forth, those bridging veins are gonna get ripped off, forming a crescent-shaped hematoma. Okay. For the lucid interval, you can see this in your epidural hematoma. That's why in epidural hematoma, you need to have an absolute GCS score of less than 8 to operate on the patient. So in subdural, you don't need to wait for it to go down to less than 8. You just need it to trend less than 2 GCS score, which is deteriorating by a score of 2, right? Among the two, which does not cross suture lines, this is your epidural hematoma, and does not cross the midline, this is your subdural hematoma. When your dura intensively attaches to your bone, so as a result, your epidural hematoma, you have your dura here, you have your suture lines around the bone. Whenever you have suture lines, the dura is attached there very tight. So what happens is that the hematoma, when it's on top of your dura, below your bone, it cannot move across your suture lines. For a subdural hematoma, if it cannot cross the midline, it's because of the falx cerebri, okay? The reflection of dura found in the middle. You have your brain tissue here, dura here. If you have a subdural hematoma, it's not going to be able to cross the midline because, again, of that falx cerebri there. Next, incomplete spinal cord syndrome characterized by weakness of the upper extremities greater than the lower extremities. We have what you call your central cord syndrome, right? Weakness of the upper extremities more than lower extremities, you have your sacral sparing, right? Sacral sparing syndrome. Again, that's your central cord syndrome. So for spinal cord syndromes, you have your anterior cord, posterior cord, central cord, and your Brown's cord syndrome. For anterior cord, you usually deal more of sensory motor weakness below the lesion, and impaired pain and temperature sense below the lesion. For posterior cord, This involves your proprioception vibration sense below the lesion. For central cord syndrome, because the nerves are arranged in such a way that if you view them from the top, there's a hole in the middle where fluid goes. The one that's affected more earlier is actually your upper extremities because it's the upper extremities in the middle and lower extremities in the periphery. Thus, if you have a problem with the center of the cord, such as central cord syndrome, the upper extremities are going to be affected first more than the lower extremities. Next, we have the Brown-Séquard syndrome, in which it's a hemitransection because only half of the cord is affected. So what happens that the motor nerves of the patient, the proprioception vibration sense of the patient is affected ipsilaterally because the motor neurons and the proprioception vibration sense of the posterior cord, the motor of the anterior, they decussate the level of the brain. So what happens is that if you have an injury much lower below, it's ipsilateral, it's in the same side. However, for your pain temperature sense, they decussate two levels below the part of the spine. Therefore, the affected part is contralateral rather than ipsilateral. Next, which of the following is false regarding silver sulfadiazine? A. Used as a prophylaxis against burn wound infections with a high range of antimicrobial activity. B. Safe to use on full and partial thickness burn wounds as well as skin grafts. C. Has limited systemic absorption. D. May inhibit epithelial migration and partial thickness wound healing. So for silver sulfadiazine, the correct answer here is letter B. Safe to use on full and partial thickness burn wounds as well as skin grafts. This is false because you don't use silver sulfadiazine for grafts because it retards epithelial migration, thus affecting the lifespan of your grafts. So you have different agents used in the treatment of burn wounds. You have first your silver sulfadiazine, which is primarily used as a prophylactic agent against burn wound infections. So the silver sulfadiazine can cause neutropenia by decreased neutrophils due to neutrophil migration to the burn site. And this is contraindicated in burns on donor sites in proximity to newly grafted areas because this may retard epithelial migration. Next, you have your mafenide acetate, which is effective because it penetrates eschar, as compared to silver sulfadiazine, and it's used both in the treatment and prophylaxis of wound infection. So silver sulfadiazine, more of prophylaxis, your mafenide acetate, both prophylaxis and treatment. It can cause metabolic acidosis, however, because it inhibits your carbonic anhydrase, your mafenide acetate, your MA, again, causes your metabolic acidosis, MA. So first letter is the same, mafenide acetate, metabolic acidosis. For silver nitrate, it has broad-spectrum microbial activity and can cause hyponatremia and methemoglobinemia. Okay. Dickens solution is used as an inexpensive topical antimicrobial and contains 0.5% sodium hypochlorite or your H. Next, the most common cause of hospital admission of burns is your flame burns, and it's also the burn type with the highest mortality. The most accurate way to determine your burn depth, however, is it's very, cumbersome and expensive, is a full thickness biopsy. Okay? However, if you do indeed do a full thickness biopsy, you're going to encounter these three zones. Your coagulation, stasis, and hyperemia arranged from the innermost to the outermost. Again, innermost coagulation, in the middle stasis, outermost you have your hyperemia. So the zone of coagulation is the most severely burned portion. It's found in the center of the wound, and it usually needs excision and grafting. The zone of coagulation. For hyperemia, so let's go straight to hyperemia. It's found in the outermost area of the burn, and it's due to vasodilation, which is compensatory to allow your blood, to allow your inflammatory cytokines, to allow your inflammatory mediators, your inflammatory cells to go into the site of injury. So it heals with minimal or no scarring. Between the three, the more important actually is your zone of stasis because it's in the middle of coagulation and hyperemia. And this one is actually, its fate is decided by resuscitation and appropriate wound care. So if you hydrate the patient, during the more intensive hours after a burn injury, so you can actually salvage the zone of stasis and convert it to a zone of hyperemia. Otherwise, the zone of stasis is going to actually become part of coagulation, and you'll have a area with bigger you'll have a bigger area that requires a more extensive surgical management, such as, again, excision and grafting in a patient with burn. Next, when we're talking about hydration, we need to memorize the Parkland or Baxter formula. So for hydration, that's 3 to 4 ml per kilogram per percent of burn. That's your Parkland or Baxter formula. And also we have your ABA or modified Parkland's formula, which is 2 ml per kilogram per percent of burn, because the ABA has identified that patients who are given Parkland's formula are usually overhydrated. So as a result, they congest. So they decided to decrease the constant factor from 4 to 2 ml per kilogram per percent of burn. Right? So the confusion arises because our more recent references is teaching us that 2 ml per kilogram per percent of burn is actually the correct answer. So I believe if you are asked in the exam to solve for the hydration for a patient who has burns and they specify ABA or modified Parklands, I think you should answer 2 cc per kilogram per percent of burn. Just because, again, they specify that it's the ABA formula or the modified Parklands. However, if the question does not specify or specifies Parkland or Baxter formula, then personally for me, I'd go with the 4 cc per kilogram per percent of burn. Just because I think that some of the questions there are actually more, how can I say this, more historical, and the examiners usually just are not really that familiar with the more recent updates. However, again, if they just specify AB or modified Parklands, you just answer 2. But if it's Parklands or non-specific, I usually just answer 4. Well, that's a personal preference for me. Next, most common parameters to gauge burn resuscitation. So burn resuscitation or hydration is assessed by your blood pressure and the urine output. Next was a scoring system used to predict mortality in burns. This is your BOW score, which is actually determined by the age of the patient and the percent TBSA. Now, when assessing the extensiveness of the patient's burns and assessing the TBSA used for hydration, for adults we use the rule of nines. So I've drawn this in such a way that they make use of the number 9s. So I hope you can copy this. So for the whole head, that's 9. That's for the front, that's 4.5. Back, 4.5. For the whole left arm up to the fingers, you have 9. Okay. For the right, that's 9. For the thorax, that's 9 in front, 9 in the back. For the abdomen, it's 9 in the front, 9 in the back. For the legs, you have 9. For the thighs, 9 for the legs. For the other side, 9 for the thighs, 9 for the legs, and 1 for the perineum. Okay. However, for children, the more accurate accounting of the burn size is not the rule of nines, but is the Lund and Browder chart. The Lund and Browder chart. Next, what type of collagen is most important in wound healing? So, letter A, type 3. Letter B, type 5. Letter C, type 7. Letter D, type 11. So in wound healing, the more important type of collagen is your type 3 collagen. We remember this is 3 pair. Okay. So what's the major component of extracellular matrix in skin? This is your type 1 collagen. A good mnemonic that I can remember for type 1 collagen is skin with the I replaced for 1 and bone, B-O-N-E, 1 there is found in bone. Skin and bone have high amounts of your type 1 collagen. Your type 1 collagen again is important in your skin and bones. Collagen type which becomes more important during the repair process. You have your type 3 collagen which serves as the scaffolding collagen. Good way to remember this is 3 pair. Repair type 3 collagen. And just to add, type 2 collagen for histology, it's your cartilage cartilage. Your type 2 collagen is found in cartilage. Now, for the phases of wound healing, you have 4 general phases. The first phase is the phase of hemostasis and inflammation. Second phase is this phase of proliferation. C is phase of maturation and remodeling. And finally, we have your epithelialization. So for hemostasis and inflammation, before inflammation occurs, you need to have hemostasis to prevent the patient from exsanguinating. So the blood flow there needs to stop. Aside from preventing exsanguination, blood loss, stopping the blood flow there allows your inflammatory mediators, your WBCs, to arrive at the site and exert their actions. So the first WBC that actually goes in your phase of inflammation is our neutrophil. They're the first cells to infiltrate the wound, and they peak at 24 to 48 hours post-injury, followed by macrophages, which peak at 48 to 96 hours post-injury. Your macrophages, they clean the area up, they get rid of the antimicrobial agents that are found there. And finally, you have your T cells, which bridge the inflammation phase to the proliferative phase, and they peak usually 1 week post-injury. After hemostasis inflammation, you have phase of proliferation. This is where you establish tissue continuity and involves the invasion of fibroblasts, which deposit your collagen, and your endothelial cells, which participate in angiogenesis, right? So for fibroblasts, the strongest chemotactic factor is actually your PDGF. Your PDGF stands for platelet-derived growth factor. And scientists have actually made use of the properties for PDGF, and they applied this because your PDGF-BB is the only FDA-approved growth factor therapy for the treatment of diabetic foot ulcers. It's in your proliferation phase, again, where you have your fibroblasts, which deposit your type 3 collagen fibers, which are your scaffolding fibers, again, 3 pair. After a phase of proliferation, you have your maturation or remodeling phase. So when you mature, you try to shift the collagen bed to a more mature collagen bed. So from a type 3 collagen, you're going to convert it into a type 1 collagen. When type 1 collagen is first laid, of course, it's haphazard, it's not really in its final state. Your body will try to realign the collagen according to the stresses and tensile pressures that are exerted upon that area. So what happens is that these type 1 collagen fibers are going to get degraded and reapplied by way of your matrix metalloproteinases. And this is what you call remodeling. It's important to remember that after a scar remodels, the strength of the tissue only approximates 75 to 80% as to it was where before it was injured. And finally, you have your epithelialization phase, which is the final step in establishing tissue integrity. It is characterized by proliferation and migration of epithelial cells. After epithelial cells have arrived there, epithelial cells can be continue to keratinize. Next, for the wound healing pearls, layer of the bowel, the greatest tensile strength and greatest suture holding capacity. So actually the strongest part of the bowel is your submucosa, and this is where you usually anchor the sutures. However, just to be sure, we need also to apply a watertight seal to prevent leaks, and this is usually a suture that takes hold of your serosa. So usually if you want to be sure, you do a 2-layered suture repair or anastomosis. You need to approximate the submucosa first, followed by the serosa after. Next was the most active amino acid in enhancing wound fibroplasia. So this is your arginine. So again, arginine is again most active in enhancing wound fibroplasia. For the vitamins most closely involved in your wound healing, you have your vitamin A and vitamin C. In wound healing, vitamin A and vitamin C. Next, most well-known element in wound healing and has been empirically used in dermatologic conditions. So this is your zinc. Okay? This is your zinc. Okay? Disease associated with zinc deficiency, you can have a patients with eczema and dermatitis. You call this acrodermatitis enteropathica. Again, for amino acid, arginine, for vitamins is vitamin A and C. For elements or trace minerals, you have your zinc. For zinc deficiency, it's again your acrodermatitis enteropathica. Also important for wound healing is the difference between your keloid and hypertrophic scar. Just remember, if you have an injury, you have a wound bed there, the wound granulates, epithelializes, and extends beyond the border of the original wound and do not regress. That's your keloid. Compared to your hypertrophic scar, in which it stays within the confines of the wound and regresses over time. Again, if it extends outside, that's keloid. If it stays within the wound, it's a hypertrophic scar. Keloid spontaneously regresses. Keloid do not spontaneously regress. Your hypertrophic scar regresses over time. Next question. The most common subtype of melanoma, is it letter A, lentigo maligna? Is it B, acral lentiginous? Is it C, superficial spreading? Or is it D, nodular? So among the four, the most common subtype of melanoma is your superficial spreading melanoma. So melanoma, again, is the most lethal skin cancer. When it grows, it starts first in a localized, just in the area, radial going outside, growth phase followed by a vertical growth phase. So if it's just spreading superficially, it's just an early phase, and it's the phase which is most common. So superficial spreading, again, is the most common subtype of melanoma, approximately 70%, and they usually arise from a pre-existing nevus. Then when it goes down, it goes more nodular, it becomes more advanced. That's why the nodular subtype for melanoma has the worst prognosis because of the prominence of the vertical growth phase. So lentigo maligna, what you just need to remember is that this occurs in older patients' population. A good way to remember this is lentigo maligna, the term sounds a bit old, so it's found in older patient populations. For acral lentiginous, so it's found in the subungual regions and glabrous skin of palms and soles. That's your acral lentiginous, subungual regions and glabrous skin of palms and soles. Next, what's the most important characteristic of the primary melanoma lesion with regards to prognosis? So again, the most important characteristic is the depth of invasion or Breslow thickness. Okay, depth of invasion or Breslow thickness. What's the most important indicator in the presence of regional lymph node metastasis of melanoma? The most important indicator for metastasis in melanoma, especially prognosis-wise, is the number of nodes affected. It's the number of nodes affected in melanoma. The most common location of distant melanoma metastasis, it's in the lungs. For men, the most common site is in the back. For women, it's in the legs. Again, men, back, women, legs. Other skin cancer pearls, most common skin cancer type, you have your BCC or basal cell carcinoma. Most common subtype for BCC is the nodular variant. Most aggressive subtype for BCC is morpheiform. Second most common skin cancer, that's your squamous cell carcinoma. And precocious skin lesion for squamous cell carcinoma, and the most common variant is your actinic keratosis. Again, most common type, basal cell. Second most common, squamous cell. For basal cell, most common, you have your nodular. Most aggressive, you have your morpheiform. Squamous cell, precursor lesion, actinic keratosis. Next, the breast receives its blood supply from all of the following except A. Branches of the internal mammary artery, B. Branches of the superior epigastric artery, C. Branches of the posterior intercostal artery, or D. Branches of the thoracoacromial artery. So the correct answer for this one is letter B. Branches of the superior epigastric artery. The internal mammary artery, posterior intercostal artery, the thoracoacromial arteries, both all give branches to your breast, except your superior epigastric artery. So for the purpose of the anatomy of the breast, so your breast is composed of 15 to 20 lobes. You have your Cooper's suspensory ligament, which provides structural support to your breast. And your breast extends from the second or third rib superiorly to the sixth or second rib inferiorly at the inframammary fold, from the lateral border of the sternum to the anterior axillary line, where you have your axillary tail of Spence, again, second or third rib, sixth or seventh in the inframammary fold, lateral border of sternum to the anterior axillary line, which is actually your axillary tail of Spence. So if you divide the breast into 4 quadrants, the one that contains a greater amount of tissue is actually the upper outer quadrant. So remember again, you have your axillary tail of Spence there. Because it is the higher amount or volume of tissue, it's the most common location of a malignant mass. Again, by virtue of it having more tissue as compared to the other quadrants. For the vascular supply of the breast, as we've mentioned in the question, your internal mammary artery, your posterior intercostal arteries, and your axillary artery giving off your thoracic, lateral thoracic, and pectoral branches of the thoracoacromial artery all provide good vascular supply to the breast. Okay. Just a recall question, a vascular pathway that extends from the base of the skull to the sacrum and provides a route of breast cancer metastasis, especially thoracic spine. You have your Batson's vertebral plexus. So Batson's vertebral plexus, again, vascular pathway that extends from the base of the skull to the sacrum. Next, for the lymphatic drainage of the breast, you have level 1, level 2, and level 3. Level 1 is lateral. Level 2 is deep, or between the two pectoral muscles. Level 3 is medial. So a good way to remember this so that I don't get confused. Level 1, the 1 there looks like an L, it's lateral. Level 3, the 3 there looks like an M, it's medial. And level 2 is just deep to the pectoralis minor muscle and can be between two pectoral muscles. So if it's between the two pectoral muscles, you call that the interpectoral group or the Rotter's nodes. Again, Rotter nodes, interpectoral group of lymph nodes in your level 2. Next, risk factors for the development of breast cancer include the following except, is it A, early menarche, B, nulliparity, C, late menopause, or D, long lactation period. So again, risk factors for the development of breast cancer include the following except A, early menarche, B, nulliparity, C, late menopause, or D, longer lactation period. So, risk factors for breast cancer involve those conditions or those demographics with prolonged exposure to estrogen. So if you have your menarche early, if you didn't have an interruption of your estrogen synthesis, especially if you haven't born any child or you haven't been pregnant, and finally, if you have a longer time period in which you're exposed to your estrogen, such as if your menopause is late, these are all risk factors for development of breast cancer, except your longer lactation period, because again, this prevents your estrogen from being produced, and actually lactation serves as one form of somehow contraception in patients who are pregnant. Now, for the risk factors for breast cancer, you have the hormonal risk factors. As we previously discussed, the presence of estrogen is a risk factor for breast cancer. You have your female gender more than the male gender, early menarche, late menopause because you have a longer time they're exposed to estrogen, obesity because your adipose tissue activates and also produces your estrogen, nulliparity because you don't have interruptions in your estrogen producing phases, and age more than 30 years old at first pregnancy. For the non-hormonal, you have your genetic. As a sample, you have your BRCA1 or 2, ataxia, telangiectasia, Li-Fraumeni, and Cowden syndrome. You also have your radiation, alcohol consumption, and dietary fat. The parameters of the modified Gale model for breast cancer risk, you have your age at menarche, number of previous biopsies, age at first live birth, number of first-degree relatives in a typical ductal hyperplasia. Again, age at menarche, number of previous biopsies, age at first live birth, number of first-degree relatives in a typical ductal hyperplasia are all risk factors for Gale model for breast cancer risk. Okay. For breast cancer, when we're talking about the imaging, it's very important to understand the BI-RADS category because they're going to put BI-RADS blank number and they're going to ask for the next management. It's really if you have case-oriented questions regarding the BI-RADS classification or categories for breast cancer or breast masses. So you actually have 7 BI-RADS categories. I have 0 to 6. So that's 1 to 6 plus your 0, that's 7. 0 is incomplete, you need to repeat the imaging. 1 and 2, that's negative. 2 is benign. Routine screening is recommended. 3 is probably benign. There's high probability of benign finding. What you do is there's short interval follow-up. So as compared to the annual screening, you need to do it 6 months in BI-RADS 3. For 4, you have 3 subgroups. You have 4A, 4B, and 4C. 4A is low, 4B is intermediate, 4C is moderate risk. So for low, intermediate, moderate risk, you need to perform biopsy, preferably needle biopsy. What we do in our setting is a core needle biopsy. For 5, it's highly suggestive of malignancy. And 6, if it's a biopsy-proven malignancy, then you do proceed with treatment. Again, 0 incomplete, 1 is negative, 2 is benign, 3 is probably benign, you do short interval follow-up. For 1 and 2, again, you do routine screening, which is annual. 4, you need to do biopsy. 5 and 6, you do appropriate actions. You can do the MRM, you can have participation for chemo, depending on your adjuvant chemotherapy, depending on what stage the patient is on in currently. Next, for breast lesions and cancer risk, you have your non-proliferative lesions, sclerosing adenosis, and intraductal papilloma, which are 3 breast lesions with no risk for malignancy. That's again non-proliferative lesions, sclerosing adenosis, and intraductal papilloma have no breast cancer risk. Florid hyperplasia has a risk of 1.52 times. Atypical ductal hyperplasia and lobular hyperplasia has a 4-fold increase. Atypical 4, the A there somehow looks like a 4 to me, or the 4 looks somehow like an A. So again, I somehow use this when I want to recall what times higher the risk factor for patients with atypical lobular ductal hyperplasia. And it's 4 times the usual. For LCIS and DCIS, it's a 10-fold increase in breast cancer risk. Now, for risk management, you have your screening mammogram, which is a baseline mammogram at the age of 35. At the age of 40, you need to do annual mammogram with annual clinical breast exam and breast cancer awareness. For age 50 to 74, you need to do it every 2 years biennial. Again, for age 50 to 74 years of age. For chemo prevention, so just high yield points there. When you have increased risk of breast cancer, like you've had DCIS or LCIS, or if you're family genetics and you have also been genotyped to be of high risk for development of breast cancer, you can give chemo prevention. So you have your selective estrogen receptor modulators, your tamoxifen and raloxifene. However, the side effect of your tamoxifen and raloxifene is that they actually predispose the patient to having cardioembolic events. That's why in older age groups, if the patient is already menopausal, you don't give your SERMs already, you give your aromatase inhibitors. Okay, you have your exemestane as a good example. Okay, because your exemestane, along with your other aromatase inhibitors, your anastrozole, they don't have the effects of side effects of cardioembolic events, no? or problems with coagulation. Now, also your aromatase inhibitors, however, has a side effect of predisposing the patient to decreased bone density. So you need to give bisphosphonates to these patients as compared to your tamoxifen. So they have their own advantages and disadvantages. Prophylactic mastectomy may be given for BRCA mutation carriers also. So in pregnancy, it occurs in 1 out of 3,000 women, your breast cancer and axillary lymph node metastases are present in 75%. So they often present at a later stage because they develop faster, because breast tissue, when you're pregnant, there's more changes that occur in a hormone-rich environment. For the first and second trimester, you can proceed to your modified radical mastectomy if you have a breast cancer that requires surgery. For the third trimester, you can proceed with lumpectomy and ALND for the reason, for the first and second trimester, you can proceed with lumpectomy only and ALND because lumpectomy and ALND or axillary lymph node dissection requires adjuvant therapy such as your chemotherapy and radiation after. So in the first and second trimester, because you can't have the patient undergo chemotherapy and radiation, it's better to proceed with the modified radical, more radical procedure just to make sure that the cancer is somehow eliminated. For the third trimester, you can proceed to less aggressive, more conservative approaches such as lumpectomy and ALND because you can provide the patient's chemotherapy after the child is born, right? So it's near the delivery date. For neoadjuvant chemotherapy may be given in the second and third trimesters because there's no evidence of teratogenicity. For breast pearls, what's the most common intrinsic infectious breast order? The most common intrinsic infectious breast order is your periductal mastitis. Periductal mastitis. Most common cause of breast pain, you have your cyclical breast pain, which are due to the hormonal changes that occur in a woman's cycle. Next, the most common cause of bloody nipple discharge is an intraductal papilloma, but the presence of a bloody nipple discharge would prompt you to work out for more malignant causes. However, still the most common cause of a bloody nipple discharge is a benign cause, again, with no risk for malignancy. It's your intraductal papilloma. You can do a ductogram or you can do an excision of the duct to diagnose the patient indeed has malignancy or is benign. Next, most common breast lesion in adolescents and young women, it's your fibroadenoma. So your fibrocystic changes are most common in patients who are premenopausal, adolescents, and young females. Most common cause of death in breast cancer patients is actually distant metastasis. Again, metastasis, most common cause of death in breast cancer patients. Next, although injury to the right recurrent laryngeal nerve results in hoarseness in unilateral injury or airway obstruction in bilateral injury, injury to the superior laryngeal nerve results in a more subtle injury affecting the ability to, is it A, speak loudly or sing high notes, B, cough, C, feel sensation in the anterior neck, or D, grimace. Okay, so when you have injury of the superior laryngeal nerve, remember the superior laryngeal nerve, okay, has two parts. You have your internal and your external branch. So the internal branch is actually more involved in sensation of the larynx. So if you don't have sensation there, you're more prone to aspiration. For the external part, it supplies one muscle, the only muscle which is not supplied below the recurrent laryngeal nerve, which is your cricothyroid muscle. Your cricothyroid muscle acts as a tensor, so when the vocal cords are tensed, the frequency increases. So if you can't tense the vocal cords, you can't increase the frequency, the patient can't speak loudly or sing high notes. The correct answer is letter A. So for thyroidectomy, especially if you're doing modified radical neck dissection, you have increased risk of nerve injuries, right? So for recurrent laryngeal nerve, for the left recurrent laryngeal nerve, remember you have your vagus nerve which goes down to your abdomen, right? From that vagus nerve, it gives off a laryngeal branch, your superior laryngeal nerve, right? Which again supplies sensation to the larynx and motor to the cricothyroid muscle. For the inferior laryngeal nerve, it goes back, it goes down, then it goes back up. So when it goes back up from the inferior, it recurs. This is why I call it recurrent laryngeal nerve. It provides to most of the muscles of your vocal cords, right? So for the left recurrent laryngeal nerve, it crosses the arch of the aorta and loops along the ligamentum arteriosum in a sense, the TE groove or tracheoesophageal groove. For the right recurrent laryngeal nerve, it crosses and loops around the right subclavian artery. Then for the left, it's the ligamentum arteriosum. That's a good way to remember it. Left ligamentum, same first letter. For the right, it's the right subclavian artery. Okay? For the superior laryngeal nerve, you have the internal and the external branch. Again, the internal branch provides sensation above the vocal cords. For your external branch, it causes inability to hit high notes. So your recurrent laryngeal nerve innervates all muscles of the larynx except the cricothyroid muscle. And the cricothyroid muscle is supplied by the external branch of the superior laryngeal nerve. So if you have one recurrent laryngeal nerve which is affected, if it's in the paramedian position, if it's beside the median, you have a normal but weak voice. If it's in the abducted portion, you're gonna have a hoarse voice and weak cough. If it's bilateral, usually the vocal cords they close. So what happens is that there is airway obstruction and this necessitates tracheostomy in the patient. So for the thyroid anatomy, it's the origin of the thyroid. It's in the base of the tongue at the foramen cecum. Base of the tongue at the foramen cecum. What's the most lateral and posterior extent of the thyroid gland? It's the tubercle of Zuckerkandl. It's the tubercle of Zuckerkandl. Next, first muscle encountered during neck dissection of the thyroid, it is your platysma, which is a superficial muscle of your neck. Next, vessel first seen after opening the platysma muscle during thyroidectomy is your anterior jugular veins. Again, after opening the platysma, the first vessel you're going to encounter and you're going to ligate is your anterior jugular veins. Next, condensation of the thyroid capsule which attaches it to the trachea. So the thyroid capsule, when it goes to the back, it condenses and makes an attachment or a ligament called your ligament of Berry. Now, if your breast has the Byrod's category, which is actually just based off the imaging, your thyroid cancers have your Bethesda. So you don't get confused. Breast, Byrod's, thyroid, Bethesda. Okay. So for your Bethesda system, it's actually based off the FNAB findings, which is again the most important diagnostic for thyroid masses, your FNAB. So you have 6 categories as compared to your Byrod's, which has 7. Your Bethesda has 6. Your Bethesda has no 0. It starts with 1, which is diagnosed, non-diagnostic, or unsatisfactory. If it's non-diagnostic or unsatisfactory, you need to repeat your fine needle aspiration, but now with ultrasound guidance to enable you to hit more accurately the lesion. Next, Bethesda 2 is benign, so you just need to do critical follow-up. Bethesda 3 is the atypia of undetermined significance, or AUS, or follicular lesion of undetermined significance, or FLUS. So if you have AUS or FLUS, you also need to repeat the FNAB, okay, just to confirm the diagnosis. For your Bethesda 4, you have follicular neoplasm or suspicious for a follicular neoplasm. You need to do only a lobectomy in patients with follicular neoplasm. However, if it's suspicious for malignancy and already malignant, you do near total thyroidectomy. Now, the key point that I'd like also to emphasize is that in Bethesda 4, it may also be a follicular malignancy, right? Follicular neoplasm is either benign or malignant. Neoplasm does not necessarily mean it's malignant. It may be benign or malignant. You need to do lobectomy, and based on the lobectomy result, you may proceed later on to completion thyroidectomy if it becomes malignant, if it's follicular carcinoma. But if it's like an adenoma or other masses which are follicular in nature, lobectomy is more than enough in these patients. Remember, when you're diagnosing thyroid masses, the most important test is actually your FNAB. However, in follicular neoplasms, you cannot identify, you cannot diagnose benign from a cancerous lesion based on only an FNAB, because the FNAB is only capable of presenting to you the cytopathology, the content, the types of cells found in a certain lesion. However, an FNAB will not be able to give you architecture. If you did a lobectomy and you demonstrated that the mass, the lesion there, the follicular lesion there, extends beyond the basement membrane and affects other parts of the thyroid, then you're thinking more probably of a more malignant lesion rather than a benign one. Right? So you can proceed again with completion thyroidectomy. But if it's papillary or if it's confirmed the carcinoma, then proceed with near total thyroidectomy. Now for thyroid masses, you can proceed to an MRND, which is a modified radical neck dissection, which again, you try to remove the nodes there to prevent recurrence and to improve the prognosis of the patient. And you need to do this in patients who are node positive, in which you've already palpated or identified via imaging that there are nodes that are increased in size or at high risk for being metastatic already. Okay, that's where you proceed with MRND or modified radical neck dissection. For thyroid neoplasm, pearls was the only test necessary in clinically euthyroid patients with thyroid nodules. So the thyroid panel is a bit expensive. So if you had to choose between the three, T4, T3, or TSH, I think it's very important for you to choose TSH first because it differentiates if the thyroid is actually hyperfunctioning or hypofunctioning. Single most important test in the evaluation of thyroid masses, again, as I've already mentioned, this has been popping out in the previous board exams. This is your FNAB. Next, age of diagnosis, which of stages the differentiated thyroid cancer. So this is 55. Before it was 45, but they improved prognosis by 55. So the staging is actually dependent on the age, again, of the patient. So if you have metastasis, but the patient is age 55 or less, so that's still at least a stage 2. However, if the patient is more than 55 years of age, then it's already a stage 4. Next, thyroid cancer with the best prognosis. This is your papillary thyroid carcinoma. And the most common sites of metastasis of thyroid cancer for papillary, this is your lungs. For follicular, this is bones. Again, metastasis for thyroid cancer, if you have papillary thyroid carcinoma, it most commonly metastasizes to your lungs. For follicular thyroid carcinoma, it commonly metastasizes to your bones. Next, a patient with primary hyperparathyroidism undergoes neck exploration where 4 small normal-appearing glands are found. What are the possible locations of an additional supernumerary gland? So usually there's 4. If there's more than 4, it's supernumerary. So the most common, actually, the common sites are your thyroid gland, thymus, and 3 grooves. So the correct answer is letter D, all of the above. Okay. So the parathyroid anatomy, usually you have 4 parathyroid glands. However, if it's not 4, 3 is more common than 5. Having 3 glands is more common than having more than 4 glands or 5 glands. So you have the superior glands and the inferior glands. The superior glands are more consistent in position and they are found dorsal at the back of the recurrent laryngeal nerve. The inferior glands are found ventral or anterior to the recurrent laryngeal nerve and they're more variable. However, the most common location is 1 cm from the point centered where the inferior third artery and the recurrent laryngeal nerve crosses. Okay? So for your parathyroid, you have your 2 types of cells. Generally, you have your chief cells and your oxyphil cells. It's your chief cells which are functional and oxyphil cells which are more supportive. So chief cells, they produce your PTH or parathyroid hormone, which increases levels of calcium and decreases levels of phosphate. Right? Your chief cells work antagonistically with your parafollicular C cells, which produce your calcitonin. Your calcitonin naman regulates your calcium levels or decrease the calcium levels. Your PTH, again, increases calcium levels. So again, thyroid, parathyroid. For your thyroid, you have your parafollicular C cells, which produce calcitonin. For the parathyroid, you have your chief cells, which produce your PTH. Calcitonin decreases, PTH increases. Both work in a negative feedback loop. For hyperparathyroidism, I think this have been more high yield in the previous board and the more recent board exams. So you have different types of hyperparathyroidism. You have parathyroid adenoma, parathyroid hyperplasia, and parathyroid carcinoma. Right? Using tests for localization such as your sesame B scan or 99 technetium, you can identify among the 4 glands which one is producing more than what is expected or is at a high index of suspicion of possible hyperparathyroidism. So if it's only 1 gland, you call this a parathyroid adenoma, and usually it manifests as asymptomatic hypercalcemia. What do you do to the patients with parathyroid adenoma? You remove that adenoma, you do single gland parathyroidectomy. As compared to parathyroid hyperplasia, in which you use a sesame B scan and the 4 parathyroid glands light up, meaning the 4 of them are hyperfunctioning. So you can't just remove 1 or 2, you need to remove 3 and a half. You leave a half there so that that half of a parathyroid can still produce your calcium. So you do 3.5 parathyroidectomy, or you remove the 4 and transfer it somewhere else. Most commonly, it's a sternocleidomastoid or the forearm, where you reimplant your parathyroid. For parathyroid carcinoma, you have severe hypercalcemia. You do end-duct removal of the tumor with the involved thyroid lobe, the cervical thymus, and contents of the central compartment. And you do adjuvant radiotherapy in high-risk or select patients. So the parathyroid, again, the inferior parathyroid glands being very variable in location. When you want to remove them, you do sestamibi scan. If you missed it, okay, so there's a difference between a missed gland and an ectopic gland. When you missed the gland, means that the gland is still there, you just can't find it. So a missed gland, the most common location is it's in the normal anatomic location. If it's in the ectopic, if it's an ectopic gland, it's really outside the normal location of the parathyroid gland. It's usually found in the thymus. Okay, in the thymus. Next, classic pentad of symptoms of hyperparathyroidism. You have the kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones. Okay, again, say it with me. Kidney stones, painful bones, abdominal groans, psychic moans, and fatigue overtones. Classic pentad of symptoms for hyperparathyroidism resulting in hypercalcemia. Okay. So in outpatients, the most common cause of hypercalcemia is your primary hyperparathyroidism. In inpatients, the most common cause of hypercalcemia is malignancy, either by excess production of your PTH or by production of a similar protein, a PTH-related protein. Again, in outpatients, it's primary hyperparathyroidism. It's usually asymptomatic. If the patient is admitted, usually it's due to malignancy, cause of hypercalcemia. Next, the most common branchial cleft fistula originates from the A. First branchial cleft, B. Second branchial cleft, C. Third branchial cleft, or D. Fourth branchial cleft. So among the four, the most common is the first branchial cleft fistula. So branchial cleft anomalies, your branchial cleft, they are paired. The clefts and arches, they develop in the 3rd and 4th week of life. If they are persistent, if they are still present when the child is born, you call that a persistent branchial cleft. And if there's a problem, it's an anomaly. Usually there's a fistula there. The 1st to 4th branchial clefts give rise to adult organs. Again, branchial cleft anomalies usually present in the first decade of life, and the treatment is usually complete excision. Unless infected first, you can do an INT. So the first three are very high yield. The first branchial cleft starts from the middle ear, internal opening out to the preauricular area, middle ear to the preauricular area. For the second, third, lateral neck at the sternocleidomastoid. For the second, internal opening is the tonsillar fossa. Okay. Third, you have your piriform sinus. Again, first, middle ear to preauricular area. Second, tonsillar fossa to lateral neck at SCM. Third is piriform sinus and lateral neck at the SCM. Next, all of the following are false about salivary gland neoplasms except A. Account for less than 2% of all head and neck neoplasms. B. If in minor salivary glands, less likely to be malignant than if in the parotid glands. C. CT scan is more accurate than MRI in detecting lesions. And D. Oncocytomas are usually malignant. Okay. So this is a double negative questions, false except. So what you do is you try to find the correct answer. So letter B is incorrect because minor salivary glands are more likely malignant than the major parotid gland. MRI is actually more accurate than your CT scan because of its ability to differentiate soft tissue borders. And oncocytomas are usually benign. So the correct answer is letter A, account for less than 2% of all head and neck neoplasm. This one is the correct statement. So again, salivary gland neoplasms, they're uncommon, only 2%. 85% arise within the palatal gland. Okay? Majority of palatal neoplasms are benign. Right? Again, most commonly, your salivary gland neoplasms develop in the palatal gland. Unfortunately, those majority of your palatal neoplasms are actually benign. So only 25% are malignant. 50% of tumors in the submandibular and sublingual glands, however, are malignant, while 75% in the minor salivary glands are malignant. So the less common you go in salivary gland neoplasms, more common palatal, less common minor salivary glands, the more chances of malignancy you have. So minor salivary glands, you have a higher risk of malignancy as compared to palatal glands. A most sensitive study to determine soft tissue extension and involvement of adjacent structures because of its ability to delineate soft tissues better. It's your MRI rather than a CT scan. So you have the demonic 25, 50, 75. 25% of palatal gland neoplasms are actually malignant, 50% of submandibular or sublingual glands are malignant, and 75% of minor salivary glands are malignant. What's the most common salivary gland tumor? This is your pleomorphic adenoma. Again, most common salivary gland tumor is your pleomorphic adenoma, otherwise known as your benign mixed tumor. Next, what's the second most common salivary gland tumor? This is your Wharton's tumor. However, if the specifier there asks for the malignant salivary gland tumor, the most common is your mucoepidermoid carcinoma. Okay? So your mucoepidermoid carcinoma is the most common, again, malignant salivary gland tumor, followed by adenoid cystic carcinoma in adults and actinic cell carcinoma in children. Again, adenoid cystic carcinoma in adults, a good way to remember this is AD, adenoid adults. Actinic cell carcinoma, however, is in children. Okay? For adenoid cystic carcinoma, it has the buzzword neural spread usually in the case. Carcinoma x pleomorphic adenoma is an aggressive malignant tumor arising from a benign mixed tumor. We have the rule of 80s for palatal gland and benign neoplasm. 80% of salivary gland neoplasms occur in the thyroid. 80% of those found in the palatal gland are benign, and 80% of those benign tumors are your pleomorphic adenoma or benign mixed tumor. Next, Pancoast tumors are identified as involving all of the following except A. The chest wall at or below the second rib. B. Tumors to the parietal pleura or deeper structures overlying the first rib. C. The superior sulcus. Or D. The extreme apex of the chest. Okay. So Pancoast tumor are identified as involving all of the following except the chest wall at or below the second rib. Because it's not the second rib, it's in the first rib. So Pancoast tumors are any tumors of the superior sulcus of the lung, including tumors without evidence for involvement of the neurovascular bundle. Okay. They involve the parietal pleural or deeper structures overlying the first rib, not the second rib. Okay. Pancoast tumors, first rib. And the treatment is usually multidisciplinary, whether if it's affecting the vasculature, the nerves, or the pulmonary status of the patient. So if the neurovascular bundle is affected at the superior sulcus, you're going to have what you call your Horner syndrome, which is your meiosis, ptosis, and anhidrosis. Meiosis means constriction because of the parasympathetic innervation. Ptosis means looping of the eyelids, and anhidrosis means an abscess of sweating, which are more or less more of parasympathetic effects of impingement of that neurovascular bundle there. Then your Horner syndrome is associated with Pancoast tumors. For the pearls, lung pearls, we have pattern of classification in most hamartomas. So hamartomas are actually just lung tissue found in the lung also, but are haphazardly or irregularly placed. The calcification that you found in most hamartomas is popcorn calcification. Next, Most important risk factor for lung cancer, it's your smoking. Most common type of lung cancer, it's your adenocarcinoma. The most common type of lung cancer, it's your adenocarcinoma. Next, FEV1, which indicates that the patient can tolerate a pneumonectomy. A patient can tolerate pneumonectomy, meaning removal of the whole lung if the FEV1 is increased more than 2 liters. For FEV1 is again a pulmonary function test in which you try to let the patient exhale for 1 second and you identified how many ml of air the patient has expired. That's forced expiratory volume at 1 second. If it's more than 2 liters, then the patient can tolerate pneumonectomy because the other lung can provide for the functional capacity of the lung that will be removed. FEV1, which indicates that the patient can tolerate a lobectomy. So a lobectomy is of lesser extent as compared to a pneumonectomy, because in lobectomy you just remove a lobe. So an FEV1 more than 1.5 is good already. Next, which of the following is the most common type of ventricular septal defect to require surgical correction? Is it A, ostium primum? Is it B, ostium secundum? Is it C, muscular? Or D, perimembranous? So the most common type of VSD that requires correction is your perimembranous VSD. So your VSD refers to a hole between your ventricles, the left and the right. The most common type requiring surgical correction is your perimembranous VSD. Okay, determines the initial pathophysiology of disease. It's the size of the VSD, because the size of the VSD will determine that the patient will have increased shunting. Okay, the problem with shunting is if the flow is not left to right, but instead right to left. If it's left to right, it's okay because the left ventricle has oxygenated blood. If the left shunts to the right, what's passing through again to the lungs is oxygenated blood, and there's no problem in having excess oxygenation. However, the problem is if the right ventricle has higher pressures now due to increasing pulmonary resistance, what happens is that blood from the right ventricle goes to the left side. If it goes back to the left side, it bypasses the lungs. If it bypasses the lungs, means that the blood is not getting oxygenated, your patient will desaturate. So you call this the Eisenmenger syndrome. Again, normally in a VSD, the flow of blood goes from left ventricle to right ventricle because the left has a higher pressure than the right. The left ventricle has oxygenated blood, therefore oxygenated blood going from left to right is of no or little consequence. Problem is, if the pulmonary pressures are increased, the right ventricle compensates by increasing its pumping pressure also. Instead of the blood going from left to right, the blood will go now from right directly to left. If it goes from the right directly to the left, it has bypassed the lungs. If it bypassed the lungs and the blood is not oxygenated, this is what you call your Eisenmenger syndrome. Next, the most common cardiac tumor is A, papillary fibroelastoma, B, lymphangioma, C, myxoma, or D, metastatic tumor. Okay. The most common cardiac tumor is your myxoma. Okay, again, most common cardiac tumor, myxoma. 75% arise in the interatrial septum between the two atria near the fossa ovalis in the left atrium. So left more than right, more commonly affected by your myxomas. Macroscopic features are it's pedunculated, it has a stalk with a gelatinous consistency, and contains cells that arise from a multipotent mesenchyme and contained with a mucopolysaccharide stroma. So in children, the most common primary cardiac tumor are tumors of the muscle, your rhabdomyomas. Most commonly resected cardiac tumor are your fibromas, on the other hand. Again, in children, most common rhabdomyomas. If resected, the most common are your fibromas. Next, the bypass conduit with the highest patency rate is it A, radial artery, B, internal thoracic artery, C, greater saphenous vein, or D, radial arteries. These vessels are actually used, the four of them. However, the one with the highest patency rate and is most preferred is the internal thoracic artery, otherwise known as your internal mammary artery. Okay. So for your CABG or coronary artery bypass, the most important criterion in conduit selection is the patency of the graft. You want to decide which vessel to graft in the coronary arteries by identifying which vessels have greater patency rate. How long can they stay open over time? So that's graft patency. The highest patency rate conduit is your internal thoracic artery. So it's attached proximately to the subclavian and anastomosed distally to the target coronary artery. But your other radial artery, greatosaphenous vein, and the radial artery can all be used as bypass conduits. So again, the best patency rate is demonstrated by your internal thoracic or internal mammary artery. Next, which of the following is the most typical presenting symptom in a patient with aortic dissection? So in a patient with aortic dissection, they usually complain of, is it A, tearing pain, B, paraplegia, C, abdominal pain, or D, a cold left arm? So the initial symptom is usually that of tearing chest pain. So aortic dissection is the most common catastrophe involving the aorta. The classic presentation is severe chest or back pain described as tearing that migrates distally. Again, that's a tearing pain, aortic dissection. If the pain is more prominent in the anterior chest, this is usually aortic dissection of the ascending aorta. If in the back and the abdomen, it's usually the descending or the thoraco-abdominal portion of the aorta. Again, if it's in the anterior, it's still the ascending aorta, anterior. If it's in the back, it's the descending and thoraco-abdominal aorta. What's the most common cause of death during non-operative treatment of descending aortic dissection? This is the rupture of the aorta and malperfusion of the end organs. Because remember, the aorta provides for the most of the major organs. If there's a problem, there's obstruction, there's dissection, there's bleeding out, then the end organs, especially your kidneys, are affected also. Next, most common location of an aortic aneurysm. Is it A, suprarenal aorta, B, infrarenal aorta, C, thoracic aorta, or D, your iliac artery? So the most common location of an aortic aneurysm is the infrarenal aorta. So below the renal arteries is your infrarenal aorta. It's actually very good because if you have infrarenal aortic aneurysms compared to suprarenal ones, you can do aortic cross-clamping without increased fear of actually affecting the kidneys, because again, you clamp below the renal arteries, because if you clamp high up, you're gonna affect the perfusion of the kidneys. So you clamp so that you can allow time for the surgeon to repair the aorta when it's open and aneurysmography is done. When you place a graft there. So again, an abdominal aortic aneurysm or AAA is defined as a pathologic focal condition or dilation of the aorta that is greater than 30 millimeters or 1.5 times the adjacent diameter of the normal aorta. Okay. The most common location is infrarenally, and again, it's a good thing somehow because you can do cross-clamping below the kidneys without fear of injuring the kidneys and having the patient undergo acute kidney injury. The most common cause of an abdominal aortic aneurysm is a degenerative process of the aortic wall. So this table just shows the annualized risk of rupture of abdominal aortic aneurysms based on size. You can scan this table if you have time. Next, an ankle brachial index that suggests increased risk of myocardial infarction would be: is it less than 0.9? Is it less than 0.6? Is it more than 0.9? Or is it more than 0.6? Okay. The ankle brachial index is when you compare the BP of the ankle to that of the brachial artery. Okay? The ABI is problematic if it's less than 0.9. So the ABI is determined by taking the higher pressure of the two arteries of the ankle divided by the brachial arterial systolic pressure. So this is used to evaluate patients at risk for cardiovascular events. So you want actually the ankle to have higher pressures as compared to your brachial arteries. Because if it's lower, it means that the ankles or the lower extremities are not being perfused as much as the upper extremities. So the one that's at increased risk of myocardial infarction and peripheral vascular disease is an ABI level of 0.9. Okay. Okay, just also remember that there's ABI ratios 1 to 1.29, that's normal. More than 1.30, there's usually a non-compressible vessel. If it's less than 1, 0.99 to 0.91, it's borderline. 0.90 to 0.40, it's mild. And severe, that's less than 0.4. Next, for the esophagus, squamous cell carcinomas of the esophagus most commonly occur. Is it A, the GEJ, B, in the cervical and upper thoracic esophagus, C, in the lower thoracic esophagus, or D, evenly distributed throughout the esophagus? Again, squamous cell carcinomas most commonly occur in the cervical and upper thoracic esophagus. So keywords in answering this question here is your squamous cell carcinoma, okay, and the most common there, because remember you have two general types of esophageal neoplasms. Basically, you have your adenocarcinoma and your squamous cell carcinoma. If you know the risk factor, you're gonna know where it's most commonly located. So for esophageal neoplasms, the most common type of esophageal cancer worldwide is ciliary squamous cell carcinoma. However, in developed countries, it has shifted from squamous cell carcinoma to adenocarcinoma. The most common type in the middle third of the esophagus is your squamous cell carcinoma. Okay, that's in the middle, cervical to middle third. Because remember, squamous cell carcinoma, the most important risk factor for this is smoking. And among the three portions, first, second, third portions of the esophagus, the one that's initially and most exposed to smoke is the cervical and the thoracic portions. Okay, squamous cell carcinoma, smokers, first and second portions of the esophagus. Okay. Common in the distal third of the esophagus, you have your adenocarcinoma. Because the risk factor for adenocarcinoma is your Barrett's esophagus. Okay, so Barrett's lesion is a metaplasia of the normal squamous epithelium of the esophagus to the more intestinalized columnar epithelium. So again, your esophagus is usually supposed to have squamous epithelium. However, if it's exposed to too much acidity, it's going to transform to a type of mucosa which is capable of handling that same acidity, which is more of an intestinal type or a columnar type. So from transition, a metaplastic transition from a squamous type to columnar type, you call it a Barrett's esophagus, and it's a risk factor for adenocarcinoma. So again, Barrett's esophagus occurs because of the excess irritation by your acidity, probably from a problematic gastroesophageal junction, or again, excess acidity, which will predispose the patient again to metaplasia and eventually adenocarcinoma. So again, first, second portion of the duodenum, you have your squamous cell carcinoma because of the smoking risk factor. Distal third of the esophagus near the stomach where your acidity occurs, you have your Barrett's metaplasia there. Adenocarcinoma, it's in the acid portion or the part of the esophagus which is affected by acid, the distal esophagus. Next, which of the following disorders involve simultaneous non-peristaltic contractions of the esophagus? Is it A, achalasia, B, diffuse esophageal spasm, C, hypertensive lower esophageal sphincter, is it D, your nutcracker's esophagus? If it's simultaneous non-peristaltic, this is otherwise known as your letter B, diffuse esophageal spasm. Again, simultaneous non-peristaltic contraction, your diffuse esophageal spasm. The most common esophageal motility disorder, it's your nutcracker esophagus. Now, don't get confused. Even though if you encounter achalasia is not the most common. But however, achalasia is the classic one. It's the one that's usually being asked in board exams or in your quizzes. However, between your four common esophageal motility disorders, it's your nutcracker esophagus actually, which is the most common. Again, achalasia is just more well known, but more common still, nutcracker esophagus. So you have four general types of motility disorders. You have your achalasia, hypertensive LES, DES or diffuse esophageal spasm, and your nutcracker's esophagus. Okay, so in order to memorize or again to understand and to answer questions which give you manometric readings or pressure readings and try to let you surmise or deduce what type of motility disorder the patients have is by differentiating them first by their LES pressure. LES there stands for lower esophageal sphincter pressure. The sphincter there at the esophagus at its junction with the stomach. Okay? If it's high, it's either achalasia or hypertensive LES. Again, if it's high, it's either achalasia or hypertensive LES. How do you differentiate? Hypertensive LES is just hypertensive LES. It's just high LES pressure. However, achalasia has high LES pressure but no peristalsis, wherein your hypertensive LES has normal, again your achalasia has no peristalsis. Okay. Next is diffuse esophageal spasm. For diffuse esophageal spasm and your nutcracker esophagus, the LES pressure is normal. It's okay as compared to again achalasia and hypertensive LES. The problem with DES and your nutcracker's esophagus is not the LES actually, but it's the peristalsis that occurs. For your DES, it's diffuse spasm. It occurs all throughout. You're gonna think high amplitude, uncoordinated. There is no coordination. As compared to your nutcracker esophagus, again, nutcracker esophagus means it's just like a nutcracker. It's just squeezing. It's high amplitude, but it's coordinated still. Again, diffuse esophageal spasm and your nutcracker's esophagus both have normal LES pressure, but it's your DES which is uncoordinated and nutcracker which is coordinated. Okay, for achalasia, cutting the lower esophageal sphincter to allow passage of food into the stomach in achalasia. So in achalasia, again, you have LES pressure which is high, so you cut, you make an incision toward there to split the muscles and allow the LES to relax. So this is called your Haller's myotomy. And you can do this laparoscopically. In Haller myotomy, you incise in the muscle to allow your esophagus, the LES, to relax. Next question. The most accurate diagnostic test for Zollinger-Ellison syndrome is it A, fasting serum gastrin? Is it B, computed tomography scan? Is it C, endoscopy? Or is it D, a secretin stimulation test? Again, the most accurate diagnostic test for Zollinger-Ellison syndrome is your secretin stimulation test. That's the most accurate test for Zollinger-Ellison syndrome. So for Zollinger-Ellison syndrome, it's hypergastrinemia in the presence of elevated basal acid output. So again, this is otherwise known as your gastrinoma. Your gastrin-producing cells in your pancreas, when they are neoplastic and they produce in excess, again, this is called your gastrinoma, they can produce increased acid output by virtue of the effect of the gastrin levels. This is what you call your Zollinger-Ellison syndrome. So the confirmatory test for ZES is your secretin stimulation test. Although your secretin is supposed to increase your gastrin levels, in the patients with gastrinoma and you put secretin, it's going to increase even more. So if you increase the IV bolus, if you give an IV bolus and you check gastrin levels, if you give secretin, if you have gastrinomas, it's going to increase more than 200 picograms per ml. Next, we have your gastrinoma or Passaro triangle. For gastrinoma Passaro triangle, you have your cystic duct and the CBD as one edge, the pancreatic neck and the body as one corner, and the second and third portion of the duodenum. It's usually in this triangle where you find most of your gastrinomas. Again, cystic duct, CBD, pancreatic neck and body, the second and third portion of the duodenum. Next, so what's the single best study for localizing gastrinoma tumor? It's the octreotide scan. So octreotide actually localizes the receptor for your gastrin production, your gastrin cells. Therefore, an octreotide scan would preferentially go to somewhere where gastrin levels or gastrin production is very evident. So if not found, if you can't find the gastrocnoma, even after using octreotide scan, you can decide to open up the duodenum, put a hole there, and try to explore the duodenum. So you call this a duodenostomy or duodenotomy. Next, the optimal initial management of a patient hospitalized for a bleeding peptic ulcer is it A, ulcer over Su? Is it B, vagotomy and pyloroplasty? Is it C, distal gastrectomy? Or is it D, intravenous proton pump inhibitors? So the initial management for a bleeding peptic ulcer is not surgical, right? It's usually conservative at the onset unless the patients present with contraindications for conservative management, such as hemodynamic instability and a surgical peritonitic abdomen. So for peptic ulcers, these are focal defects in the gastric or duodenal mucosa that extend to the submucosa or even deeper. This is usually due to imbalances between mucosal defenses and acid or peptic injury. So what are the complications of your peptic ulcer disease? The most common complication is actually first, your bleeding. So you're going to have a patient who presents with upper GI bleeding, either with hematemesis or melena, right? But if the bleeding is too severe, your patient can also present with hematochezia, which is more lower GI than actually upper GI actually. However, again, upper GI bleed, if it's too voluminous, if it's too in excess, it can present as lower GI bleeding somewhat because hematochezia, again, is usually present in your lower GI bleeding. After bleeding, the most common complication is perforation. Okay, there's a hole there, and gastric contents gonna come out into the abdominal cavity, and they're gonna cause a peritonitis. Or you can have your gastric outlet obstruction due to chronic inflammation, possible adhesions, or the edema, or a malignancy which was born out of your chronic irritation. So for peptic ulcer disease, number one complication again is your bleeding. Again, it's the most common. Presents with melena or hematemesis with or without shock. But again, hematochezia may be present if the blood is actually very voluminous. The blood loss is very voluminous. Because again, blood is actually a very great prokinetic. So if you have lots of blood there, it's just gonna go pass out through. It's still bright fresh red. Again, it's fresh red is usually lower GI bleeding because it's near the anus. However, you can again also have hematochezia in the patients with upper GI bleeding. So how do you diagnose peptic ulcer disease? Insert an NGT. Bleeding, insert an NGT. If you aspirate it and you see bleeding, you proceed to endoscopy. By endoscopy, it's very important to understand that doing an endoscopy is not only diagnostic, it's also therapeutic. Right? For a patient who has bleeding peptic ulcer disease who is stable, you can place the patient in NPO. You can suppress the acid production of the stomach by virtue of using your proton pump inhibitors, or you can do endoscopic treatment, which are less invasive rather than your surgical treatment by use of epinephrine or cutlery. So what are the indications for surgery for your bleeding peptic ulcer disease? Persistent bleeding or rebleeding after endoscopic therapy. If there's significant hemorrhage, more than 4 units. In elderly patients with comorbidities, if it's found in the posterior duodenal bulb and there's high risk of rebleeding based on endoscopic findings, then you can proceed to surgery. But otherwise, manage it conservatively. Next, you have your perforation. Then number 2, most common perforation. Usually presents as an acute abdomen because of the spillage of gastric contents with marked abdominal girding and rebound tenderness. So when you want to identify a perforation, remember, the X-ray that you want to request is not an abdominal X-ray, although in some abdominal X-rays you can diagnose a perforation. But the first line, the best diagnostic imaging for your perforated peptic ulcer disease is a chest radiograph. Because a chest radiograph, especially if it's upright, where air will go up, will demonstrate a pneumoperitoneum in 80%. Okay. However, it's still 80%, there's still 20% who have perforated peptic ulcer disease that will not present as pneumoperitoneum, So still, it's an important differential even if you don't have a new peritoneum in X-ray. However, again, an upper chest film is the best initial test or imaging for your perforated peptic ulcer. Treatment is operative most of the time. However, it may be non-operative if sealed without signs of peritonitis. Okay? However, if there's peritonitis, there's hypotension, there's sepsis, then you can proceed with OR. So for your classifications of peptic ulcer disease, you have the Johnson classification in which where your bleeding or where your perforation is identified, you have 1 to 5. So 1 is found in the anrum in the lesser curvature. It's only 1. For 2, there's 2, duodenum and the anrum of the stomach. 3, it's in the pre-pyloric junction. It's at the distal end of the stomach just before it becomes the pylorus. 4 is the hilus curvature, so near the esophagus, the GEJ. And 5 is NSAID induced. So again, the 5, the most common is your type 1. So again, anemonic 1, there's only 1. 1 first, the first letter of the alphabet is A. Remember A, anrum. So 1, most common, anrum, found only found in lesser curvature and is only 1 in number. As compared to 2, which means there's 2 in number, it's found the first 1 is found in the duodenum, and the second one is found in the anrum. 3, pre-pyloric junction. 3 rhymes. Okay, so 3 rhymes. Pre-pyloric means it's at the distal end of the stomach just before it becomes the pylorus. If it's in the proximal end of the stomach, in the high lesser curvature, just when the esophagus ends and becomes the stomach, you have the high lesser curvature there. You imagine it like a door. It opens into the stomach. So 4 sounds like door, high lesser curvature. 5 is NSAID induced. NSAID has 5 letters. NSAID induced is Johnson 5. Next, for other complications, the third one, you have your gastric outlet obstruction and present with non-bilious vomiting. Why non-bilious? Because again, bile is produced in the duodenum. If the obstruction is at the gastric outlet or the pyloric sphincter, then the vomiting is supposed not to have any bile there. If the vomiting is in excess, it can progress to electrolyte and acid blood gas abnormalities because again your gastric contents are high in hydrochloric acid. It's going to lose hydrogen and chloride. If it's going to lose hydrogen, you're going to have alkalosis. If you're going to lose chloride, it's become hypochloremic. The potassium there, it just shifts along with the hypochloremia. So it's hypokalemic, hypochloremic, metabolic alkalosis. Okay, just remember that. So other findings are your succussion splash, in which you're sloshing around her during sudden movement of the patient. Remember, you have a full stomach with an obstruction there. Try to move the patient, you're going to hear a sloshing sound. Most commonly, it's identified in the stomach. So diagnostic for GOO, from a peptic ulcer disease, is endoscopy. Treatment is usually conservative until the patient has severe GOO, then you can proceed to operative management already. Now for the tests of peptic ulcer disease, test of choice when endoscopy is not indicated, you can do serology, which is a less invasive test. For confirming cure, you can give the patient a urea breath test to identify the presence of H. pylori, and you want to confirm that this H. pylori is causing the peptic ulcer disease. You can give tissue samples after endoscopy, an histologic test. However, when endoscopy is necessary, the simplest method to identify H. pylori short of doing tissue biopsy is by subjecting the tissue to a urease test. We apply certain substrates which converted to urea. You have a rapid urease test. If it's positive, then it means that there's H. pylori because your H. pylori has urease. What's done for repeated failure of medical treatment? You have culture and sensitivity because some of the H. pylori are already resistant to some antibiotics that we give for patients with peptic ulcer disease. Next, which of the following options is the best management for a low-grade gastric lymphoma at the gastric antrum? Is it A. H. pylori eradication, B. Chemotherapy and radiation therapy, C. Wedge resection, or D. Atherectomy? Your low-grade gastric lymphomas are actually most commonly due to chronic irritation of the stomach. Chronic irritation of the stomach can be caused by your H. pylori. Therefore, for low-grade lesions, treating the main source, your H. pylori, actually treats the lymphoma also. So the first line in patients with low-grade lymphomas, you eradicate H. pylori or Helicobacter pylori. So your gastric lymphomas, 50% actually of your GI lymphomas are arising from your stomach. The rest are in the intestines. 95% are non-Hodgkin's type, and most are B cell type. Okay, non-Hodgkin's type, B cell type, and are thought to are derived from your mucosa-associated lymphoid tissue or MALT. Risk factors are chronic gastritis, gene mutations, transplant immunosuppression, IBD, inflammatory bowel disease, and your HIV infection. But the main culprit, the most significant factor there is your H. pylori, Helicobacter pylori infection. So again, if it's low grade, it's non-surgical. Remove H. pylori first. If it's not, if it's persistent, you can proceed to radiation therapy after. Okay. If in advanced lesion, you can do H. pylori treatment, EBRT or radiotherapy, then followed by chemotherapy, then endoscopic surveillance. For high-grade gastric lymphomas, treating H. pylori there is not of that it's not of importance already because it's already high-grade. So you can proceed with chemoradiation for most cases. And surgery is reserved for urgent situations of tumor complications like acute hemorrhage, obstruction not relieved by steroids, or a failure of response to your chemoradiation. That's for high-grade gastric lymphoma. Again, low-grade, it's non-surgical H. pylori treatment. If H. pylori treatment is not enough, you can give radiation. If it's advanced, you can give chemotherapy. If it's high-grade, chemoradiation outright, no need to treat initially for H. pylori. And surgery is if there's incomplication, if it's not responding, and if there's failure of your actually chemoradiation. Next, standard treatment for an isolated 3 cm gastrointestinal tumor in the body of the stomach. Is it A. Imatinib, B. Endoscopic ablation, C. Wedge resection, or D. Subtotal gastrectomy? Okay. The standard treatment for GIST in the body of the stomach is wedge resection. You only get that portion of the stomach with a GIST. So for GIST, they arise from the interstitial cells of Cajal, which are actually your pacemakers of your GI system. They coordinate peristalsis. The prognostic factors for GIST are your tumor size and mitotic count. So the larger the tumor, the more mitosis, the poorer prognosis. So your GIST is usually submucosal in location and metastasize hematogenously. That's why endoscopic biopsy is actually not the tell-all for your GIST tumors or GIST tumors because usually it's submucosal. So even if you do perform endoscopy biopsy, sometimes you might not get the correct diagnosis. But still, endoscopy biopsy is still first line. However, I'm just emphasizing that it's not really that specific. Tumor marker is by using c-KIT, your CD117, again c-KIT, CD117, and your CD34. c-KIT, CD117, and CD34 are tumor markers for your GIST. Presentation is asymptomatic, and usually it presents with bleeding. Okay, bleeding, because your GIST usually, they outlive their blood supply. If there's areas of necrosis, they're prone to bleeding. Again, you can do endoscopy and biopsy, but again, due to its submucosal nature, sometimes you can't get enough yield, you can't diagnose really a GIST from a simple biopsy because again, it's submucosal. What you usually get from endoscopic biopsy are the mucosal tumors, and you can use a CT scan to identify if they have morphologic features or imaging features similar to GIST. Treatment is wedge resection with negative margins. If you have unresectable metastatic GIST, you can give the patient imatinib. Okay, imatinib, which targets your BCR-ABL, your imatinib, otherwise known with the brand name of Gleevec. Again, imatinib, tyrosine kinase inhibitor, targets BCR-ABL, otherwise known as your Gleevec. Next, a pocket or sock-like outpouching on the antimesenteric side of the distal ileum, called a mecal diverticulum, is caused by A. Excessive traction in the intestine during childbirth, B. Increased intraluminal pressure, C. A persistent vitelline duct, or D. A mutation to the c-MEC gene. Again, Meckel's diverticulum is caused by, the correct answer here is letter C, a persistent vitelline duct or an omphalomesenteric duct. Okay? So Meckel's diverticulum is when you have persistence of the vitelline duct, which is actually communication of the gut of the fetus with the yolk sac. So if they fail to obliterate, you call them as Meckel's diverticula. So if the rule of twos for Meckel's diverticula, it's 2% of the population, 2:1 male predominance, 2 feet proximal to the ileocecal valve, and 1/2 of symptomatic patients are under the age of 2 years. 2 types of mucosa are seen, gastric more commonly than pancreatic. It's the gastric mucosa there that actually predisposes patients with Meckel diverticulum to bleeding, 2 inches in length also. Remember, the units used for measurement in your Meckel diverticulum is of the American system rather than the metric system. Therefore, it's feet rather than meters and inches rather than centimeters, because this is a question which the examiners will try to trip you up by asking which of the following rule of twos is not a part of the rule. So sometimes you're gonna interchange feet with meters, again, and inches with centimeters. Don't get thrown off. Meckel uses the American system rather than the metric system. The most common presentation of a Meckel diverticulum in children is that of bleeding, because again of the gastric tissue, which irritates the surrounding intestinal mucosa, causing bleeding. You also have again, heterotopic gastric mucosa. You can also have in adults, the most common presentation is obstruction because of the subsequent inflammation, adhesion, and edema or fibrosis around that area. Next, the most common cause of small bowel obstruction A is incarcerated hernia, B. Crohn's disease, C. Malignancy, or D. Post-operative adhesions. Again, most common cause of small bowel obstruction is your adhesions or post-operative adhesions. So your small bowel obstruction is the most common surgical disorder of the small intestines. Again, your mechanical SBO is the most common surgical disorder of the small intestines. 75% are due to adhesions and most are related to prior abdominal surgery. But take note, you can also have adhesions which are not post-operative. So just don't get confused. Most common cause of small bowel obstruction are adhesions. Okay, the second most common cause of small bowel obstruction is a hernia. Okay. If adhesions are ruled out, the second most common cause you're going to think of is hernia. Again, most common adhesions, whether post-op or not. If a second most common is being asked or there's no adhesions choices, the next answer you'll answer is your hernia. What's the triad of radiographic findings in your SBO? It's dilated small bowel loops. Remember our 369 rule. For small bowel, it's 3. For large bowel, it's 6. For cecum, it's 9. If you have dilated small bowel loops more than 3 centimeters, differential air fluid levels, you're going to see their air fluid levels in the patients with small bowel obstruction and paucity of air in the colon, then that's the triad for your small bowel obstruction. Next for ileus. What are the symptoms and signs of intestinal obstruction in the absence of a lesion causing mechanical obstruction? So for ileus, you have a temporal sequence actually after an operation. So you have your SGC, mnemonic SGC. In the first 24 hours, the small intestines are gonna be undergoing peristalsis first, followed by your stomach, followed by your colon, right? Small intestines first, 24 hours, gastric 24 to 48 hours, in 2 to 5 days, that's your colon. So mnemonic I have for this is SGC, Student Government Council, SGC, small intestines, G, gastric, and C, colonic. That's the temporal sequence of normal GI motility. That's why it's not really reliable to hear bowel sounds and to assume that the patient is not in ileus, so the patient can be fed. Why? Because bowel sounds, which are contributed more or less by your small intestines, can still have an ileus or can still have the stomach and colon not functioning properly even if you have bowel sounds in the small intestines, because the sequence again is 24 hours small intestines, stomach 24 to 48, then colon for the next 2 to 5 days. Okay. So after surgery, if there is an interval, there's a gap between you feed the patient after surgery, was most probably due to physiologic recovery pa of your small intestines, stomach, and colon. You call that post-operative ileus. But remember, small intestines, stomach, and colon, up to 5 days. So if you have ileus, if you have problems in the passage of flatus or stool up until 5 days, this is somewhat relatively normal. So this is called your post-operative ileus. However, if it's more than 5 days or with the following findings: nausea, vomiting, inability to tolerate oral diet over 24 hours, absent of flatus over 24 hours, occurring on or after day 4, without prior resolution, this is called a prolonged post-op ileus. Again, a post-op ileus is almost always expected, okay? Because again, there's a temporal sequence of the GI system to return back to its normal function. Again, 24 hours small intestines, 48 hours gastric, and 5 days colon. However, if it exceeds the 5 days we have given for the colon to recover, or if it has, again, the aforementioned symptoms on day 4, then it's called a prolonged post-operative ileus. Again, post-op ileus is different from prolonged post-op ileus. Next, short bowel syndrome has been arbitrarily defined in adults as having an intestines to what length? Is it 300, 200, 100, or 50? So short bowel syndrome is defined as standard definition of a 200 cm length of residual small bowel. However, the functional definition is insufficient absorptive capacity resulting in diarrhea, dehydration, and malnutrition. So you have 3 types of small bowel syndrome. Type 1 is small bowel resection with high output jejunostomy. So you've removed the ileum and the end of it. It's the most challenging to manage because your jejunum has jejunum, when it's in high output, there's a problem really with your high output losses. Type 2 short bowel syndrome is small bowel resection with partial colon resection and resulting enterocolonic anastomosis, so a jejunocolon. So this is the most common type. Type 3, small intestine resection with small bowel anastomosis and intact colon. So best tolerated with the most adaptive potential. So most challenging, type 1, most common, type 2, best tolerated with the most adaptive potential, that's your type 3 small bowel syndrome. It's important to understand that jejunal resections are better tolerated than your ileal resections because the ileum has actually so much function in the absorptive capacity of the whole length of the intestine also, hormonal and also absorptive functions of the intestines. So resecting the jejunum is actually better than resecting the ileum. Next, a 65-year-old man presents to the emergency department with fevers, abdominal pain, and bloody stools for the past 2 days. On CT scan, he is found to have diverticulitis with scant free air and a small fluid collection associated with the sigmoid colon. What is the etiology of the diverticulitis? Is it A, lack of dietary fiber causing small stool volume requiring higher intraluminal pressure? Is it B, chronic contraction causing muscular hypertrophy, causing the colon to act as segments rather than a continuous tube? Is it letter C, the mucosa and muscularis mucosa herniate through the colon wall? Or is it D, all of the above? So the correct answer here is actually all of the above. Lack of dietary fiber, chronic contraction, and herniation of the mucosa and muscularis mucosa are actually all factors for diverticulosis. So when you have a diverticulum, it means an outpouching. You can have a true or false diverticula. So for colonic diverticula, otherwise known as your diverticulosis, most are actually false diverticula. When you say true diverticula, it will have the 3 layers of the colonic wall. It means that the outpouching contains all the 3 layers because it increased in size technically by itself. So it's a true diverticula. However, when you say a false diverticula, otherwise known as a pulsion diverticula, it means that a thickness somewhere here in the colonic wall allowed the first 2 internal layers to go out, right? So the weakness actually caused the outpouching. It did not increase in size by itself, but it's only because of the weakness of the abdominal wall. So it's a false diverticula as compared to a true diverticulum. So diverticulosis occurs usually between tinea coli, usually at areas where the arteries penetrate, because it's in these areas where the colonic wall has defects, because again, these are the areas where the arteries penetrate. So these are the weakest portions of the colonic wall. Again, it's a false diverticula or a pulsion diverticula because it's the pushing which causes, again, the colonic wall to weaken, allowing your mucosa and submucosa to extend outside. The most accepted theory for diverticulosis is a lack of dietary fiber. So if you don't have dietary fiber, what happens that the stool volume is smaller. If it's smaller, it's not going to get pushed back efficiently to your anus. So what the colon does is it tries to form better stools or bigger stools, so it increases the pressure of the intestines, allowing it to form larger stools, and these larger stools are now able to be pushed outside. So it might seem a bit counterintuitive that diverticulitis is caused actually by small stools. However, if again try to think that the colon cannot push small stools into the anus, it needs to make the small stools to bigger stools in order for it to push it. In order for it to make bigger stools, it's gonna need more pressure to form bigger stools. If there's more pressure, remember, again, diverticulosis is due to a weakness of the colonic wall. If there's more pressure, there's more chances for the mucosa and submucosa to herniate. If it herniates, again, you now have a diverticulum, which is false, otherwise known again as a pulsion diverticula. Diverticulosis commonly presents with bleeding because, again, these areas where the diverticulum are vascular areas. However, your diverticulitis is an infection associated with diverticula. So usually they present with pain at the left lower quadrant by virtue of diverticulitis being most commonly caused by your or associated with your sigmoid colon, alteration in bowel habits, and a tenderness in palpation. So you have 4 types or stages of your diverticulitis. Stage 1, you have diverticulitis with abscess just around the colon, pericolic. If it's distant, that's stage 2. It's in the back of the colon or the pelvic area, retroperitoneal or pelvic distant abscess, that's stage 2. If the peritonitis is already somewhat generalized but it's just made out of pus, that's stage 3, purulent peritonitis. If it's already filled with feces, it's stage 4, fecal peritonitis. For stage 1 and stage 2, you can have the options of doing conservative management or percutaneous drainage. Okay. For stage 3 and stage 4, however, you are now prompted to do an open procedure. You can do a Hartmann's procedure by dissecting that part of the sigmoid colon affected plus a colostomy, especially in stage 4 or in patients who are highly unstable. Next, the most common intestinal segment associated with volvulus. So the most common intestinal segment associated with volvulus is, the correct answer is actually letter A. So that's a typographical, that's an animation error. Correct answer here is the sigmoid colon. So the volvulus is the twisting of an air-filled segment of bowel about its narrow mesentery. Remember, the blood supply of a certain segment of the bowel comes from its mesentery. So imagine this, the mesentery, you have the colon here. If the colon twists, what happens is the mesentery also twists. If it twists, it will impinge upon its blood supply, causing possible ischemia. So that's a problem with your volvulus. So when there's twisting around its narrow mesentery, it can also cause a closed loop obstruction. The most common type of volvulus, 90% of the time, is your sigmoid volvulus. The second most common is your cecal volvulus. Again, the previous question had a typo. It's sigmoid volvulus rather than cecal. The reason why the sigmoid is more commonly associated with volvulus because it's the most mobile. Remember the pathophysiology of volvulus, it's twisting. So if it's twisting, the most common segment affected is the one that's actually most susceptible to twisting, the one that's always moving. It's your sigmoid volvulus. And it's actually the most redundant. It has longer loops as more than it needs to actually pass through the feces down to the anus. So diagnostic, you can do a contrast enema or identify a bird's beak deformity. So bird's beak deformity means there's a transition point where you place your enema there. For the abdominal scan, you're going to find a whirl pattern because the twisting of the mesentery is going to look like a whirl. And again, still the bird's beak appearance for the oral and rectal contrast. So the treatment, first line, especially if the patient is stable, you can do a rigid proctosigmoidoscopy with a flexible sigmoidoscopy. So if you pass, imagine this is twisting, okay? So if it's twisting, if the patient is stable again with no signs of peritonitis, you can do endoscopy or proctosigmoidoscopy. You pass a tube there, the twisting will relieve itself as the tube passes through the more proximal portions. Okay, so that's your volvulus. In patients with viable bowel and who are adequately prepared, you can do resection. You need still to resect that part of the sigmoid colon, the cecum, which has underwent previous volvulus, but you may anastomose. In patients who have volvulus with unstable vital signs, very surgical abdomen, intraoperatively, you identified that the bowel is very ischemic, there's peritonitis already, and it's unprepared. So you can do resection of the sigmoid colon with construction of a colostomy or a Hartmann's pouch, okay, rather than an anastomosis. Next, a 63-year-old man undergoes a screening colonoscopy and is found to have a polyp in his sigmoid colon. Which type of polyp is most associated with malignancy? Is it tubular? Is it villus? Is it tubulovillus? Or is it a 1 centimeter polyp? So this question is asking for the type of polyp, especially in the colon, which predisposes to malignancy. So usually they identify these two pathologically. If you identify a villus adenoma, then you're going to have a high chance of malignancy of approximately 40%. Okay. So for adenomatous polyps of your colon, these are dysplastic lesions that occur up to 25% of the population older than 50 years of age. The risk of malignant degeneration is related to both the size and the type of polyp. Okay. So we have your tubular, tubulovillus, and villus. It's actually a range from most common to least common, tubular being most common, villus being least common, and it's also around a range from least carcinogenic to more carcinogenic. Okay. So your tubular adenoma, more common but has the least cancer risk, Villus adenoma, less common but has the most cancer risk. Again, tubular adenoma, most common, can be found throughout the large intestine and is usually pedunculated. It has a stalk. Tuberculous adenoma is found throughout the large intestine, and villus adenoma again is least common but has the highest morbidity or mortality rates. Again, how do we remember this? Villus sounds like villainous. So villus, villainous, villain, villus adenoma, most cancer risk, least common. Next, ideal resection of colonic carcinoma involving the hepatic flexure. Is it A, right hemicolectomy? B, is it an extending right hemicolectomy? Is it C, a left hemicolectomy? Or is it D, a rectosigmoid resection? Okay, so for those affecting the hepatic flexure, you need to do an extended right hemicolectomy. Okay. It's important to be familiar of these colonic resections because there are some questions which give you the type of colonic resection, or they're going to give you the location of the cancer, and they're going to ask what blood vessel you want to ligate in this type of colonic resection. So for cecum, you can do a right hemicolectomy, which will involve the terminal ileum, the mid-transverse colon. Okay? So you ligate the ileocolic artery, the right colic artery, and between the two branches, remember you have your ileocolic, you have your right colic, you have your middle colic here, which is divided into the right and the left. You remove the right branch of the middle colic artery along with the ileocolic artery and the right colic artery. For ascending colon, you still can do right hemicolectomy still, terminal ileum to mid-transverse colon, still again ileocolic artery, right colic artery, and the right branch of the middle colic artery. For the hepatic flexure, because it's so far up, it's already near the transverse colon, you need to extend it a little bit more. So in the hepatic flexure, again, you can do an extended right hemicolectomy. So when you extend it to the distal transverse colon rather than the proximal transverse colon. So again, extended right hemicolectomy, you now involve the ileocolic artery, right colic artery, and the whole middle colic artery, because you don't need to separate into the right or left because you're going to remove the distal transverse colon. So again, you remove the ileocolic, the right colic, and both branches by the main trunk of the middle colic artery. For the splenic flexure, you have an extended left hemicolectomy. You just can't do a left hemicolectomy. Simply, you just need to extend it to the proximal after the more proximal mid-transverse colon. For extended left hemicolectomy, you need to remove the left branch of the middle colic artery, left colic artery, and the inferior mesenteric artery, which will supply the rectosigmoid. Now, a good way that I remember this is if you have flexure there, it's usually extended. Hepatic flexure, extended right. Splenic flexure, extended left. For descending colon mass, you can do a left hemicolectomy, which involves splenic flexure down to the rectosigmoid. You remove the inferior mesenteric artery, which will supply the left, the more distal portions. In the sigmoid colon, you can do a rectosigmoid resection. You remove the distal descending colon to the rectosigmoid junction. Minimum number of nodes for adequate staging of colorectal carcinoma, it's 12. How about for breast? It's 10 to 15. Now for colorectal carcinoma staging, they've asked T&M questions which just describe the layer of the bowel involved. So for T1, it's submucosa. For T2, it's muscularis propria. For T3, it involves the subserosa or non-peritonealized pericolic or perirectal tissue. T4 invades other organs or structure. N1, multi nodes, N2, 4 or more nodes, N3, any node along a major vascular trunk. So up to the muscularis propria, it's still stage 1. Again, submucosa to muscularis propria, it's still stage 1, but without any node involvement. Okay? So for stage 2, it's T3 to T4, subserosa up to other organs, but still without nodal involvement, that's stage 2. If you now have nodal involvement, then that's stage 3 at least. If you have metastasis, that's stage 4. So Your colorectal carcinoma staging, although they've been asked previously, they're somehow easy to memorize because again, 1 is T1 to T2, submucosa of to muscularis propria. 2 is subserosa to other organs. Again, T3, T4, that's 2. Both 1 and 2 are N0. Once they become N1, it's automatically a stage 3. If there's M1, then it's automatically a stage 4. Next, the following are features of internal hemorrhoids except is it A. Located above the dentate line, B. Covered with mucosa, C. Associated with bright red bleeding, or D. Covered with anoderm. The correct answer for this question, the following are features of internal hemorrhoids except the correct answer here is actually again, a typographical error here, is actually letter D, covered with anoderm. Your internal hemorrhoids are located above the dentate line. They are indeed covered with mucosa, and they are associated with bright red bleeding. But they're not covered with anoderm because anoderm covers your external hemorrhoids, in the contrary. So your hemorrhoids are actually normal cushions of submucosal tissues containing blood vessels. They play a role in maintaining your continence. So prolapse of the submucosal veins cause your symptomatic hemorrhoids. So you have 3 hemorrhoidal piles, your left lateral, with mnemonic is LL, right anterior and right posterior, LL, RARP. LL, left lateral, RARP, right anterior, right posterior quadrants of the anal canal. So we have the sliding anal cushion theory, which means that repeated stretching causes fragmentation of the submucosal muscle of Treitz, which anchors and suspends the anal lining again. So repeated stretching or straining can cause again the submucosal muscle of Treitz to weaken. So we have 2 types. You have your internal and external hemorrhoids, which are identified based on their location from the dentate line. If it's above, it's internal. If it's below, it's external. If it's above, it's covered with mucosa, and mucosa is asensate. You cannot feel it. Therefore, the patient usually presents with bleeding rather than pain. For external, it's covered with anoderm, basically like your skin. Your skin is sensate. It can sense pain. If it can sense pain, the early presentation of external hemorrhoids are itching and pain around the anus. Next, management. So you need to identify again if it's external or internal hemorrhoids. For external hemorrhoids, if it's in the intensive phase, which means it's within 72 hours, you may offer the patient an elliptical excision of the external hemorrhoids under local anesthesia. However, if it's already more than 72 hours, studies have shown the patient will usually recover spontaneously. Although a part of the hemorrhoid may still be there, there might be a sentinel pile which relates to it. But usually more than 72 hours, you don't need to offer surgery. You can only conservatize it because again, they usually regress after 72 hours of the attack. For internal hemorrhoids, grade 1 to grade 4 is important. Again, it's only the internal hemorrhoids which have grading, not the external hemorrhoids. For internal hemorrhoids, grade 1, there's no extension beyond the anal verge. Grade 2, there is reduction, but it's spontaneous. Grade 3, you need to manually reduce the hemorrhoids, and grade 4 cannot be reduced. For 1 to 4, the initial management can be medical, unless there is already complications such as bleeding, infection, or severe patient is uncomfortable or there's obstruction already. For 1 and 2, after failure of medical management, you can proceed to office-based procedures such as sclerotherapy versus RBL or rubber band ligation. For 3 and 4, you can proceed to surgery. Take note that in your grade 1, sclerotherapy and RBL, they're only used for your internal hemorrhoids. No matter how small the external hemorrhoids are, or how benign it looks, or how the case will actually try to push you to answer office-based procedure for external hemorrhoids, you do not answer banding or sclerotherapy for external hemorrhoids. Why? External hemorrhoids are sensate because they are covered in anoderm, which is basically your skin. If they have skin there, if you place a rubber band around it or you place a sclerosing agent on it or in it, you're gonna cause the patient severe pain. Okay. So again, RBL exterior therapy are only for internal hemorrhoids. For grade 3 and 4, you may offer surgery. You can have the Milligan Morgan open and the Parks Ferguson close technique, or also the Whitehead's excision. Next, there's also questions which try to differentiate a prolapse versus a hemorrhoid. Right? So how do you differentiate? If the tissue folds are circumferential, it's usually a prolapse because one segment of the bowel went out. It's not just one side. It's the one segment, one circumferential segment that went out. So we're gonna look circumferential. Okay. Is there a sulcus between the prolapse and the rectum? Yes, it's circumferential because again, there's a separation from the rectum and the prolapse. Okay? As compared to the hemorrhoids, which are just an extension or swelling, so you're not gonna see a sulcus. And the tissue folds because again, it's just one side, they're radial. Okay? So abnormality and palpation for rectal prolapse, you're gonna feel a double rectal wall. For hemorrhoids, it's just the hemorrhoidal plexus, which is thin-walled as compared to a double rectal wall. For rectal prolapse, if you place a finger in and ask the patient to strain, if the pressure is decreased, then it's a rectal prolapse. If it's normal, it's a hemorrhoid. Again, tissue folds and sulcus for rectal prolapse. There's circumferential. For hemorrhoids, there's no tissue fold. There's radial tissue folds and no sulcus. On palpation, you have a double rectal wall for rectal prolapse. For hemorrhoids, you have hemorrhoidal plexi. And again, decreased pressure for rectal prolapse and normal for hemorrhoids. Next, which of the following physical signs is associated with the correct definition suggestive of acute appendicitis? Is it A, Robsing sign, pain the RLQ and palpation of the left lower quadrant? B, Dunphy sign, pain the RLQ with palpation of the left? C, obturator sign, pain with extension of the leg? Or D, Eliassoa sign, pain and internal rotation of the right hip? So which one is correct? The correct answer is letter A. Robsing is pain in the RLQ on palpation of the LLQ. So Dunphy sign is actually pain elicited in the right lower quadrant after coughing. Obturator sign is pain with rotation of the right hip, and Eliassoa sign is pain with extension. So it's actually reversed your letter C and letter D options. So acute appendicitis is inflammation of the appendix caused by obstruction of the appendiceal lumen. It's the most common cause of an acute surgical abdomen. Most common aerobic and anaerobic bacteria isolated in perforated appendicitis. It's your Escherichia coli, and aerobically it's your Bacteroides fragilis. Again, E. coli and Bacteroides fragilis, both gram-neg, aerobic and anaerobic. Etiology, most of the time, it's usually due to a fecalith which has obstructed the appendiceal lumen, causing hypertrophy of lymphoid tissue. As it distends, as it dilates, it's going to outlive its blood supply. If there's no blood supply, there's going to be an area of ischemia. What happens that area of ischemia will eventually rupture. The rupture will cause fecal material, will cause peritonitis, will cause an abscess later on for the patient. So the prime symptom of your acute appendicitis, the first symptom is periumbilical or diffuse pain. Then it becomes localized in the RLQ, usually less than 24 hours. Now, the reason for this is that remember you have two peritoneal linings in your abdomen, a visceral lining which directly overlies the appendix, and a parietal lining which is again around the abdomen which houses your appendix, right? So for the first part, you're going to have periumbilical pain because the visceral peritoneum, the visceral peritoneum of the appendix, when it's stretched out, stimulates the same nerve root as your sympathetic fibers, which supplies the T10 dermatome. Again, the visceral peritoneum of your appendix, again, the first layer, the outside covering of the appendix, your visceral peritoneum, has the same nerve supply as the sympathetic fibers of the T10 dermatome. And remember, the T10 is found in the umbilicus. So the first one that is actually happening is a visceral pain which is referred to the umbilicus because the umbilicus T10 dermatome shares the same nerve root as the sympathetic fibers of your appendix. So as the appendix distends or when it ruptures, causing inflammation and irritation of the parietal peritoneum. The parietal peritoneum is the one outside. Okay, the parietal peritoneum, remember, is attached to your abdominal wall, and the pain of your parietal peritoneum is somatic, which means you identify what part of the abdomen is really affected because it's in that part where it's feeling pain the most. Because again, the parietal peritoneum is really affected. Okay, so from a non-specific or periumbilical pain, it's gonna localize to your right lower quadrant pain because the visceral peritoneum being affected first gradually shifts to the parietal peritoneum being affected by, again, by extension of the inflammation or by rupture. The Murphy triad for acute appendicitis is pain, vomiting, and fever in sequence. It's pain first, then vomiting. Because if it's vomiting more before than pain, it's usually due to an obstruction. So in physical examination, you can find the McBurney's point 1/3 from the anterior superior iliac spine to the umbilicus. And this is where we usually do your McBurney's incision or Rocky Davis incision. We differentiate a Rocky Davis from a McBurney's incision because the McBurney's incision is oblique. A Rocky Davis incision is transverse. If it's transverse, the reason why your Rocky Davis is being preferred more than your McBurney is because a transverse incision will allow you to extend medially and laterally. Okay. You have the Lanz point, which is the right third point of the interspinal line, and the Kummel's point, which is the right side below the umbilicus, which are relatively other points where your appendicitis or your appendix can be palpated or the pain can be elicited. So you have different signs of appendicitis. You have the Aron sign, which is referred pain in the epigastrium or precordial region on continued firm pressure. Your Bastler sign, when you pinch the appendix using the thumb and the iliacus muscle. Bloomberg sign is transient abdominal wall rebound tenderness. Bryant sign is when you have appendicitis in pregnancy, you shift the uterus to the right, the uterus is gonna impinge on the appendix, causing pain. Cutaneous hyperesthesia, as its name suggests, hypersensitivity after sensation, the right lower quadrant. Dunphy sign is on coughing. Poker sign is migration from the umbilical to the right iliac region. Markle sign, or what we call your jar sign, or when you have the patient drop from the toes to the heels, causing the patient's body to rock and to the patient's heel or the pelvis to hit a leg to hit the floor, causing a referred pain to the right lower quadrant. Maso sign when it performs a firm swish. Rosenstein sign is when you have the patient move from supine position to recumbent posture on the left side. Rovsing sign is when you palpate in the left lower quadrant and there's pain in the right lower quadrant. Obturator sign versus an Iliopsoas sign. Iliopsoas sign, just remember, for Iliopsoas, you have the patient lie on the left side, then you extend. And when you extend there, the appendix is gonna hit the iliopsoas muscle, which means it's retrocecal, it's behind the cecum. If it stimulates or irritates the iliocecal muscle, you're gonna elicit pain. So that's the iliopsoas sign. So it identifies a retrocecal appendix versus an obturator sign in which the appendix is in the obturator muscle, which is in the pelvis. So an obturator sign, which means a pelvic appendix, is elicited when you rotate the hip internally. What happens is that the appendix is pushed to the obturator muscle, which is again in the appendix, which when stimulated again indicates a pelvic appendix. Okay. The summer sign is increased abdominal muscle tone on exceedingly gentle palpation of the right iliac fossa, and tenor sign is pain caused by general traction of the spermatic cord. Okay, so this has appeared in a previous board exam or two, a negative appendectomy. If you opened the patient and you did not identify appendicitis, what you should do next, number one, is you should explore the peritoneum very extensively to rule out contributing pathology. Okay, it might be adenitis, it might be a mass, there might be a adnexal problem, especially if it's female. There might be secondary peritonitis from a ruptured hepatic abscess or a diverticulitis. Then remove the normal appendix to reduce future diagnostic dilemma. Okay? So again, if you open the abdomen, negative appendicitis, explore. If you don't find anything, what you should do next is remove the normal appendix. Why? Because the patient again has pain later on, the lateral quadrant, then you can safely say that it's not due to the appendix, but due to an underlying pathology. Then you work up the patient some more. Okay. In patients who have their abdomen opened for another reason, you may remove the appendix. You call this an incidental appendectomy if you have the following criteria. If the patient is undergoing chemotherapy, in patients who are disabled, in patients with Crohn's disease, especially if the patient has healthy cecum, individuals about to travel to remote areas, and may have major operations such as urinary bowel diversions, and it's routinely performed in the LADS procedure. Okay? Just want to emphasize here, Crohn's disease, you remove the appendix in a patient with Crohn's disease if the cecum is healthy. Okay? Why? It sounds counterintuitive also, because if you're thinking, I should remove the appendix if the ileocecal region in the cecum is bad looking in the person with Crohn's. Is really not practiced because removing the appendix in a patient with inflammation of the cecum in a patient with Crohn's will predispose the patient to undergo fistula formation, thereby exacerbating the problem. So you actually just remove the appendix in a patient with Crohn's disease if the cecum is normal. So again, it's counterintuitive, but just understand you want to prevent fistula formation. You don't remove it in diseased cecum, especially in patients with Crohn's disease. In LADS procedure, your appendix is actually again removed because in LADS procedure, you do this for malrotation. So in malrotation, you're going to have problems identifying or in palpating patients or identifying the problem by physical examination because in malrotation, the appendix is not in its usual location. So if you open the patient up for malrotation, just remove the appendix so that you won't get confused later if you have a patient with a problem in his abdomen who has underwent operation for malrotation or LADS procedure because you've already removed the appendix again. Next, while reviewing pathology of a recent laparoscopic appendectomy, you note that in addition to acute appendicitis, the patient had a 1.5 cm carcinoid tumor located at the base of the appendix. The patient is otherwise healthy and recovering well from surgery. What would you recommend? So should you do nothing? A. Should you do a right hemicolectomy? B. Should you do a radical appendectomy? C. Or should you do an adjuvant chemotherapy? So this one, you thought it's appendicitis, but when you operated on the patient, you had your suspicions confirmed on a histopath. It's actually a mass. It's a carcinoid tumor, which is a neuroendocrine tumor. Okay? So if you have a carcinoid tumor, most important here is actually the location of the tumor. So for in this case, it's in the base and the size of the tumor. So if it's in the base, don't need to think of anything else. You can do a right hemicolectomy. You need to complete the surgery and remove the whole right colon because if it's at the base, it most probably has metastasized or extended to the right colon. So you should remove the whole right colon. Okay. So again, appendiceal carcinoids are one of the more common neoplasms. Most common site of GI carcinoid, again, is your appendix. If less than 1 cm, they do not require additional therapy. If it's more than 1 or 2 cm, if it's found the base, you do a right hemicolectomy. If it's at the tip of the appendix, you can do an appendectomy only. If it's at the base or if there's mesoappendiceal invasion, you can do a right hemicolectomy. Again, just to emphasize for the size. If it's less than 1, regardless of location, you don't need to do anything else after an appendectomy. But you've removed it, you've checked the histopath result, it's less than 1 cm. The patient asks for, doctor, should I undergo additional procedures? You should answer no, because it's less than 1 cm. But if it's more than 1 cm, then you need to identify the location. If it's at the tip, medyo malayo na from the base, it's at the tip. So what you do is you just assure the patient and say niya, there's less likely chances for the tumor to have extended or metastasized. Therefore, we don't need to do anything for more than 1 cm at the tip tumor. However, if it's on the base it's in the base, what happens that you have higher risk for it extending or metastasizing. So you offer the patient, after an appendectomy, histopath results came to you at the base, more than 1 cm, you offer the patient's completion right hemicolectomy. So other tumors of the appendix aside from a carcinoid tumor is an appendiceal adenocarcinoma, usually mucinous. Rarest where survival is your signet ring carcinoma. Treatment, regardless of size, regardless of location, when you read adenocarcinoma, not carcinoid tumor, if you read adenocarcinoma, you do a right hemicolectomy if the patient comes back to you with an appendiceal carcinoma. For a mucocele, this is cystic dilation of the appendix containing mucoid material. It's usually benign, but it may be malignant. For benign, they're usually non-inflammatory obstruction of the proximal lumen. For malignant, is usually due to a cystadenocarcinoma. So they treat it, you do appendectomy with wide dissection of the mesoappendix and all lymph nodes. If the cystadenocarcinoma has extended to the peritoneum and you see diffuse collection of gelatinous fluids and mucinous implants on peritoneal surfaces and omentum, you call this a pseudomyxoma peritoneae. So what you do is you do surgical debulking, appendectomy, omentectomy, and TAP. So basically, you reduce the tumor burden by removing everything that peritoneal implant has touched, and you may do HIPEC, hyperthermic intraperitoneal chemotherapy. So basically what you do, you're just doing chemotherapy but inside the abdomen, directly on those peritoneal implants. Next, which of the following incorrectly matches a grading scale for patients with liver disease in one of its component? Is it letter A, model of end-stage liver disease, serum creatinine, B, Child-Pugh bilirubin, C, Child-Pugh INR, D, model of end-stage liver disease albumin. The correct answer here is letter D. Model of end-stage liver disease albumin. Right. For Child-Pugh, you have 5 parameters. You have bilirubin, albumin, INR, encephalopathy, and ascites. Your bilirubin, albumin, INR, or BAI, are your laboratory parameters for CTP. Your encephalopathy and ascites are your clinical parameters. So for Child-Pugh, it predicts the risk of portacabal shunt procedures. Okay. As compared to your MELDS, which is the actually more accepted method for organ allocation for liver transplantation, it used to predict mortality after transjugular portosystemic shunt. So your MELD is based on creatinine, total bilirubin, and INR. So actually the only similar parameters for CTP and your MELD is your total bilirubin and your INR. CTP has albumin, ELD or MELD has creatinine. Your CTP has clinical findings, also your encephalopathy and your ascites. So the most significant manifestation of your portal hypertension from liver disease are your esophageal varices. Okay? It's the leading cause of morbidity and mortality. This is due to shunting back of the blood from the portal circulation, which is hypertensive, because there's again a problem with the blood supply of your liver. There's probably something obstructing a blood vessel or a portal vein there. So what happens is they backflow and they go to areas with collateralization and connection between the portal system and the systemic circulation. One of these are your esophageal veins. So the management for esophageal varices may be pharmacologic. You can use vasopressin, which is again a vasoconstrictor, or you can use an octreotide, which is the current preferred agent. If you have bleeding, you can do early endoscopy and variceal ligation or sclerotherapy. 80% of the time, it's effective. If it fails, you can do more aggressive treatment. You do a balloon tamponade, you insert a balloon there and expand it, hoping that the expansion of the balloon will tamponade the bleeding. Is otherwise known as your Sengstaten Blakemore tube. Last line of treatment, if you have persistent esophageal varices, you can do shunting. So you want to remove the shunt system from the varices and you want to replace it somewhere else. So you can do it artificially using a systemic shunt. You transect the esophagus, another option, or devascularize the GEJ by a Sugiura-Fukugawa procedure. For child A, you can do a surgical shunt. For childs B and C, you only are offered tips. Next, for the liver, the most common benign hepatic lesion is the A, hemangioma, B, simple cyst, C, adenoma, or D, bile duct hamartoma. So the most common benign hepatic lesion is the letter B, simple cyst. So if you're asked for the most common lesion of the liver, you answer simple cyst. But if you're asked solid benign masses, you answer hemangioma. Again, lesion, simple cysts. Overall, simple cysts. But if you're specified solid masses, most common delivered, that's your hemangiomas. Okay. Most common liver tumor, however, is metastatic, usually from colorectal cancer. Most common primary malignancy of the liver in children is a hepatoblastoma. In adults, it's HCC or hepatocellular carcinoma. Second most common of the liver, cholangiocarcinoma. Again, just to emphasize, overall, most common, simple cysts. Right. If you're asked solid benign masses, these are hemangiomas most commonly. If you're asked tumors, usually malignant, the answer metastatic colorectal cancer. If it's primary, in children, it's hepatoblastoma. In adults, it's hepatocellular carcinoma. Second most common malignancy is your cholangiocarcinoma. Next, what's associated pathogen in pyogenic liver abscesses? So in pyogenic liver abscesses, it's associated with your, actually the correct answer here is your Escherichia coli. So most common liver abscess, that's your pyogenic abscess from Escherichia coli. Your parasitic liver abscess after travel to endemic area with poor sanitation and limited access to clean water. These are again your amoebic abscess due to your E. histolytica. And if you have an abscess with double wall, hydrated cyst, started albendazole, what's the best time to perform an aspiration? This is actually a trick question. Do not aspirate. So again, just to emphasize, again, this is again an animation error. If you have pyogenic liver abscess, what's the most common associated pathogen? This is your E. coli or Escherichia coli, not your S. aureus. However, S. aureus can also contribute, especially if it's polymicrobial. But again, the most common is still your E. coli, the most abundant gram-negative organism, which is aerobic in your intestines. So again, parasitic, you have your E. histolytica or your entamoeba histolytica. If you have double wall, you don't aspirate is a trick question because your E. granulosus causing your hydrated cysts when they explode and they reach the blood circulation, they're going to cause anaphylaxis. How do you treat pyogenic liver abscess? You correct underlying cause. You give IV antibiotics for at least 8 weeks. You can do a percutaneous drainage catheter. However, this is sometimes ineffective due to the viscous nature of the collection. So if the failure of non-operative management, you can do surgical drainage or resection. Next, what's the treatment of choice for a type 1 choledochal cyst? Is it A, observation, B, cyst resection and primary anastomosis of the common bile duct, C, resection of the common bile duct, cholecystectomy and hepaticojejunostomy, or C, D, resection of the cyst and choledochoduodenostomy? So for a type 1 choledochal cyst, you need to do a section of the common bile duct, remove the gallbladder, and do a hepaticojejunostomy. So choledochal cysts are rare congenital cystic dilations of the extrahepatic and or intrahepatic biliary tree. Usually in adults, they present as jaundice and cholangitis, and the pathognomonic sign of a choledochal cyst is a long, common biliary pancreatic channel. So choledochal cysts are basically your common bile duct, which are very large. Right? The reason for this is because of the inflammation and the irritation that occurs over time. So the reason for this is due to a prolonged or a long common biliary pancreatic channel more than 6 to 8 millimeters. So what happens is that the biliary pancreatic channel, if it's too long, it's too long, what happens is that the pancreatic enzymes which are supposed to activate in the intestines activate in the CBD pa lang. So when they activate there, it's gonna cause irritation, inflammation. As a result, your CBD enlarges. So those are your choledochal cysts. Okay. So the most common type of choledochal cyst is your type 1 choledochal cyst. You actually have 5 different types, 1, 2, 3, 4, 5. So let's try to review. Type 1 is fusiform. Fusiform 1, F, first, 1, first fusiform. Okay, so that's an easy way to remember it. Type 1 is the first fusiform, letter F. Management is excision. You excise it, then you attach the jejunum to the common hepatic duct or hepaticojejunostomy. Type 2 is saccular diverticulum, saccular. S2 is second, second, saccular, so we remember it. You just excise it, okay, because it's just a sac, there's a stalk, you just excise it and close the defect by tube. Type 3 choledococele, so, okay, so usually it's found the sphincter choledococele. So a good way to remember this is 3, okay, so let me show, is 3 looks like sphincter there, okay, so what you do is sphincterotomy, okay. 4A, 4B, and 5, please bear with me. 4A is extra and intra. 4B is extra only. 5 is intra only or Calori's disease. So for 4A and 4B, you do a Roux-en-Y also. You excise and you resect. For type 5, because it's intrahepatic, and especially if it's in Calori's disease, you should do transplant. So what's the risk factor of not doing surgery in patients with choledochal cyst? You run the risk of having cholangiocarcinoma. Because again, choledochal cysts are sites of irritation. If there's irritation, over time there's going to be metaplasia, then dysplasia, then cancer. So choledochal cysts run the risk of giving the patient cholangiocarcinoma if not removed. Next, acute cholecystitis is considered A primary infectious process with secondary inflammation, B, a sterile primary inflammatory process, C, a primary inflammatory process with occasional bacterial contamination, or D, a primary autoimmune process. So acute cholecystitis is considered, letter C, a primary inflammatory process with occasional bacterial contamination. Again, not all cases of cholecystitis have infection or bacterial contamination. However, it is very difficult to identify which patients have an infection. So that's why in patients with acute cholecystitis, even if you have not confirmed infection, you should give antibiotics because it's very difficult to identify which patients have bacterial contamination and which patients don't. So cholecystitis is due to an obstruction of the cystic duct by a gallstone. So this is the initiating event leading to distension, inflammation, and subsequent edema. So 90 to 95% of cholecystitis are due to gallstones. And the toxin which mediates the inflammatory process is your lysolecithin, which is a phospholipid, which when converted becomes toxic. The main symptom of uncomplicated cholelithiasis is biliary colic, which is just right upper quadrant pain that is spasmodic. And the diagnostic test of choice, initial test for choice for acute cholecystitis is ultrasound, where you identify distended gallbladder with thickening. So for cholecystitis and cholangitis, we have actually the Tokyo guidelines. The latest one is the TG18. For cholecystitis, you have local signs of inflammation such as Murphy sign, RLQ mass, pain or tenderness, and systemic signs of inflammation, fever, elevated CRP, and elevated BBC count, and imaging findings. For cholangitis, still it has imaging findings, but now with obstruction and signs of inflammation. Obstruction by jaundice or other enzymes or other liver profile results which indicate obstruction. Next, adequate treatment for a gallbladder cancer involving the lamina of the gallbladder includes A. Cholecystectomy followed by adjuvant chemotherapy, B. Neoadjuvant chemoradiotherapy followed by surgical resection, C. Cholecystectomy alone, or D. Extended right hepatectomy. So for patients who have gallbladder cancer, which are only involving your lamina, so the correct answer is cholecystectomy alone, letter C. Okay. So gallbladder cancer is most commonly due to an adenocarcinoma, and tumors are usually identified incidentally after removing the gallbladder for possible stones. Patient comes back to you with a histopath result showing gallbladder cancer. For T1A lesions only, which means that it involves the lamina propria only, cholecystectomy is enough. So if patient came to your clinic, Doc, I have adenocarcinoma of the gallbladder after you remove the gallbladder. But you've read that, you saw that it's only up until the lamina propria. So what do you say to the patient? It's okay. You don't have to do any more surgery. We can proceed with observation surveillance only when referred to onco. Now, for T1B to T4, we need to do an extended cholecystectomy because once it has reached the muscle layer by way of the gallbladder's lymphatics and venous drainage, it most probably at the time has already metastasized to the liver. Okay? So only T1A simple cholecystectomy alone, T1B to T4 can do the extended cholecystectomy. Next, insulinomas associated with the multiple endocrine neoplasia syndrome. Is it A, identified as a single focus, B, are sporadic in nature, C, have a lower rate of recurrence, or D, associated with 10% of insulinomas? So your Meniere's syndrome is associated actually with 10% of insulinomas. So if you have syndromic, there's usually multifocal, they're not sporadic, but instead are derived and genetic, and they have a higher rate of recurrence. So again, insulinomas, 90% are sporadic, meaning they are not transmitted by a genetic mutation from a parent to a child, and 10% are associated with multiple endocrine neoplasia type 1, usually. The Whipple triad has your symptom fasting hypoglycemia, symptomatic if there's a serum glucose level of less than 50 and the symptoms are relieved after glucose administration. So this distributed evenly all throughout the pancreas, and treatment is enucleation, especially if the patient is far from the main pancreatic duct and is less than 2 cm in size. If it's close to the main pancreatic duct and more than 2 cm in size, you can think of more aggressive, more extensive procedures such as pancreaticoduodenectomy. Next, for the pancreatic tumor pearls, most worst prognosis of all malignancies, it's your pancreas. It's the most unforgiving organ in the body. Most common malignancy of the pancreas, it's an adenocarcinoma. So your adenocarcinoma is actually an exocrine tumor. It affects the glands which produce the secretions produced by the pancreas, right? But overall, the most common still is your adenocarcinoma, whether exocrine or not. Again, that's adenocarcinoma. However, if the question specifies an endocrine tumor, which means it affects the islet cells, the most common endocrine tumor is non-functional. Endocrine tumor means it affects the islet cells, but it does not necessarily have to be hyper-functioning. It does not necessarily have to produce a hormone or is part of a hormonal group of your endocrine neoplasms of the pancreas. However, if they're asked the functional endocrine tumor, which is the most common, the correct answer would be your insulinoma. Medical management of functional neuroendocrine tumors of the pancreas, it's octreotide, except with insulinoma, so you should do surgery. So we have this very helpful illustration right here, which shows your gasinoma, your somatocytinoma, more focus in the head, insulinoma distributed all throughout, the vipoma at the tail, and glucagonoma at the tail also. Next, which of the following is the most effective prevention strategy against OPSI? What's OPSI? Overwhelming post-splenectomy infection. So the most effective prevention strategy against OPSI is vaccination 2 weeks before splenectomy, especially if this is an elective case. Okay. So OPSI is the most feared and extreme infectious complication of splenectomy. Okay? So the single most important or influential determinant of OPSI risk is the reason for splenectomy. Some studies even show that patients who have thalassemia have a higher risk of OPSI. So again, it's the indication which determines the risk of OPSI. The mainstay treatment is patient education and vaccination. How do you vaccinize? In most cases, in patients who have time to prepare, who are scheduled in an elective manner, you need to give vaccine 2 weeks prior to removing the spleen. Right? Why 2 weeks before?
You need to allow time for the spleen to produce memory cells and digest and consume the vaccines in order for it to be transmitted to the other immune systems of the body. For emergency surgery, you need to give it 2 weeks post-operatively, because remember, these are live vaccines, and if you give them too early, the patient might still be in immune suppression. They might have side effects which are unwarranted, and their body cannot process the vaccines very efficiently. Okay. The most common organisms associated with overwhelming post-splenectomy infections are those of your encapsulated organisms, your S. pneumoniae, your H. influenzae type B, and your N. meningitis. This is why we give actually vaccines for patient zoopsy that targets these three, along, of course, with your influenza vaccine, which is the fourth vaccine. For spleen, what's the most common indication for splenectomy overall? It is splenic trauma, right? The most common type of hemolytic anemia in which splenectomy is indicated is your hereditary spherocytosis. In hereditary spherocytosis, instead of your RBCs being biconcave, they're circular. As a result, they're not effective in going to your peripheral circulation. As a result, they're being eaten up by your spleen. As a result, your patient will have anemia. What you do is you remove the spleen, so then you don't have anemia, because the spleen is the one that's eating up your spherocytes. The most common cause of splenic cysts are your parasitic cysts. Most common premature of the spleen is your sarcomas. And the most common mechanism of intraoperative injury to the spleen is improper traction, especially if you do traction of the left upper quadrant. When you pull there, sometimes you pull the spleen also. So what happens is that the spleen will separate from the pancreatic tail, the pancreatic hilum, the splenic hilum will be compromised. Okay? So most common mechanism of intraoperative injury is improper traction. Next, the usual presentation of a rectus sheath hematoma is A. Unexplained anemia, B. Abdominal wall bulge, C. Sudden abdominal pain, or D. Inability to stand erect. Rectus sheath hematoma, the usual presentation is a sudden abdominal pain. Okay? Sudden abdominal pain. So rectus sheath hematoma is usually due to disruption of one of the branches of the inferior epigastric artery. It's associated with trauma, vigorous contraction, coughing, sneezing, exercise, chronic pulmonary disease, and patients on anticoagulants. Right? So how do you identify if it's really a rectus sheath hematoma by P alone? You palpate the mass, then you allow the patient to sit up. If the patient sits up and the mass disappears, remember, if you have abdominal wall problem, if you have a mass there and you sit up, the abdominal muscles contract. If they contract, if the mass is inside the abdomen and not in the rectus sheath, the mass will disappear. If it's in the rectus sheath, the mass will persist, because even if the muscles contract, the mass is still there. Therefore, a positive Fothergill sign is the presence of a mass does not change on contraction of the rectus muscle. Okay, because the mass is not inside the abdomen, but outside the abdomen and at the abdominal wall. Treatment for rectus sheath hematoma is, if stable, observed. If there's clinical deterioration, you get referred to your friendly neighborhood interventional radiologist, and you should embolize using angiographic embolization. Next, a 60-year-old woman presents with abdominal pain, and a CT scan reveals an abdominal mass. The most likely diagnosis is, so this question is basically asking what's the most common cause of an omental mass. It's a metastatic carcinoma. So primary tumors of the omentum are rare. Most commonly, they're metastatic. Most common cancer to have omental involvement is an ovarian carcinoma. That's why they do omentectomy when you have ovarian tumors. Most common primary tumor of the omentum, it's a lipoma. Because again, the omentum is basically just fat. Mesenteric tumors, the most common malignant neoplasm of the mesentery is your lymphoma, because of the rich immune nodes there, collection of nodes. Now, when you go to your omental cysts, this is due to the degeneration or inclusion of lymphatic structures of the omentum, and this is differentiated from your mesenteric cysts by your Tilao sign. Your omentum is found in front. It's freely mobile, right? It just covers your intestines. Your mesenteric is attached to the back of your abdomen and attached to your bowel in front, right? Okay. So what's the Tilao sign? So mesenteric cysts move only laterally, while your omental cysts move in all quadrants. Why? Your mesenteric cyst, again, is found at the back. They're fixed to the abdominal wall with the bowels in front. They're only holding the bowel, but they're fixed. They're stuck there, right? So for ornamental cyst, if you have a cyst here, and it can only move side to side, which would make sense for mesentery because it's fixed again. It cannot move up and down because remember, it's just fixed there. Okay? It's just basically a flap there. If it moves side to side, then that's a classic Pilau sign. It means that the cysts are mesenteric. Again, side to side, mesenteric cyst. However, because the omentum is draping in front of the intestines in the colon, if you have an omental cyst, it's not just limited to up and down or side and side. You can move it anywhere because again, it's very free. Okay. Next, for abdominal wall tumors, you also have your desmoid tumors, which just popped out in the previous board exam. This is known also as aggressive fibromatosis. This is fibroblastic neoplasms with aggressive local behavior but no metastatic potential. So these factors include your FAP, Gardner's, sporadic, previous surgical incision, pregnancy, hormonal exposure, and trauma. So what's a preferred imaging technique? You need to do an MRI because again, MRI provides better visualization of soft tissue tumors. The gold standard treatment is margin negative resection with immediate mesh reconstruction. The mesh there is because if you have such a big part of the abdominal wall, it's gonna risk herniation there. Primary radiation therapy may be an option for patients who are not good surgical candidates. Next, which of the following statements regarding umbilical hernias are true? Present in 10% of all newborns, repaired as soon as they are diagnosed. C. Adults with small, non-incarcerated umbilical hernia should undergo repair. Or D. Umbilical hernias are associated with disseminated carcinomatosis. So the correct answer here is letter A. Present in 10% of all newborns. Umbilical hernias are not repaired as soon as they are diagnosed because usually they may still resolved by the age of 4 to 5 years of age. So adults with small non-incarcerated umbilical hernia should undergo repair. If it's already in the adult stage and it's non-incarcerated and it's small, you may observe the patient. Umbilical hernias are not associated all of the time with disseminated carcinomatosis. So again, umbilical hernias, 10% of newborns, common in premature infants, usually resolved by the age of 4 to 5 years, so you may wait until that age before offering surgery to the folks. So adults with small uncomplicated non-incarcerated hernias can be followed up until symptoms recur. What are the indications for surgery in pediatric hernias? Inguinal hernia. The mere presence of an inguinal hernia in pediatric patients is an indication for surgery. Hydrocele. No resolution by 12 months. Umbilical hernia, 4 to 5 years. Again, inguinal hernia, mere presence, operate. You may schedule or you may do it emergently if incarcerated or strangulated. Hydrocele, wait 12 months because they resolve usually by the time. Umbilical hernia, 5 years. Next, the defect in gastroschisis is letter J. The defect in gastroschisis is to the right of the umbilicus. Okay, the defect in gastroschisis is to the right of the umbilicus. Okay. Gastroschisis is a defect in the anterior abdominal wall through which the intestinal contents freely protrude. Gastroschisis does not have a sac as compared to an omphalocele. Other differential points for your omphalocele and gastroschisis location. Omphalocele, O there. Remember O, it's like a belly button. Omphalocele, it's in the umbilical ring. Gastroschisis, the letter R. The way I remember it, gastroschisis, letter R, right of umbilicus. Fascial defect, variable for omphalocele. For gastroschisis, usually less than 4. For the sac is present in omphalocele, but it's not an absolute requirement because sometimes you may have an omphalocele which is already ruptured inside the uterus. So you may have an omphalocele without a sac. A gastroschisis will have no sac all of the time. For the intestines of the omphalocele is usually normal. For gastroschisis, it's usually leathery or shortened because the intestines are exposed for a long time to the amniotic fluid of the amniotic sac. As a result, they undergo different changes that they make them more hardy, more resistant to exposure. The liver for omphalocele is usually herniated, and gastroschisis is rarely herniated, it's usually just bowel. And associated anomalies for omphalocele, you have cloacal exstrophy, Beckwith-Wiedemann, which is hemihypertrophy, Cantrell's pentalogy also. For gaseous cases, it's intestinal atresia, undescended testes, and malrotation. Next, a newborn is found to have a blind rectal pouch on examination. Which of the following are not associated with this condition? Is it A. Esophageal atresia, B. Cardiac defects, C. Omphalocele, or D. Tethered spinal cord? So if you have imperforate anus, one that's associated with this condition is actually your esophageal atresia. So this again is our animation error. The correct answer here is letter A, esophageal atresia. So imperforate anus is failure of the descent of the urorectal septum resulting in a blind rectal pouch that often has a fistulous tract. Usually it's associated with urinary tract defect, but otherwise, if you're thinking of GI, it's esophageal atresia. If it's vertebral, it's the sacrum. Most common fistula in males is the rectourethral fistula. In females, it's the rectovestibular fistula. Again, just to emphasize, this is not associated. So correct answer is omphalocele pala. Okay, for imperforate anus, you may have esophageal atresia, you may have cardiac defects, and tethered spinal cord. Especially in the sacral area, you don't usually have omphalocele with imperforate anus. So this answer is actually correct. Okay. So again, imperforate anus, problems with the urorectal septum. So with the following most commons, skeletal sacrum, GI esophageal atresia. In males, it's rectourethral. In females, it's rectovestibular. But the vestibule is the one found just outside or just at the entrance of the vagina. Next, according to the NIHOS classification system that categorizes hernia defects by location, size, and type, femoral hernia is what type? So before, we used the NIHOS classification system to categorize hernia defects, but now more recently, we've been using the AHS or the European Hernia Society classification. But the NIHOS system is still important because it has been popping out in the board exam, right? So this is actually a type 3C hernia. I'll show you the next slide. So for the NIHOS classification, you have type 1, 2, 3, and 4. 4 is recurrent, so just save it for later. 1 and 2 are both indirect. 3B is also indirect. You skip 3A there, okay? 1, 2, 3B. 1 is indirect hernia with a normal ring. It's not enlarged. The internal ring is not enlarged. Type 2 is indirect hernia. Ring is enlarged, but the intestinal contents, the abdominal contents, the hernia contents do not reach up to the scrotum. It's just there. Type 3B is when you have an indirect hernia with an enlarged ring and the abdominal contents can reach the scrotum. So it's large enough to encroach upon the posterior inguinal wall. So this is your indirect hernia type 3B. Okay. 1, normal ring. 2, enlarged ring. No scrotal, no involvement of the scrotum. 3B, it's large. Bowels or omentum are already reaching up until the scrotum, that's 3B. Okay. 3A is direct. 3C is femoral. Okay, so you must skip 3A there a bit. So again, 1, indirect, normal ring. 2, indirect, large ring, no scrotal involvement. 3A is direct. 3B is indirect, large ring, involvement of scrotum. And 3C is femoral hernia. 4 is your recurrent hernia. For hernia pearls, the most common symptom of an inguinal hernia is a groin mass. Most common reason for elective repair of an inguinal hernia is pain. Okay? Most common subtype of groin hernia in men and women is an indirect inguinal hernia. Now, regardless if it's males or females, indirect inguinal hernia is the most common. The confusion arises when you ask the most common demographic associated with a particular type of inguinal hernia. Like for example, direct inguinal hernia is more common in older age groups. Okay? This statement just means that direct hernias are common in elderly patients. But overall, still, the most common is an indirect. Next statement, which confuses students usually, is femoral hernias are more common in women. So when you are asked in the exam what's the most common hernia in women, some students will answer femoral hernia, which is not actually exchangeable. In women, the most common still is an indirect inguinal hernia. It's just that for femoral hernias, the most common are women. Again, overall, there is age, demographic, male or female, most common indirect inguinal hernia. Direct hernias are common in elderlies because it's usually due to weakness of the abdominal wall as compared to the patent processus vaginalis defect for indirect hernia. In women, femoral hernias are associated with women, but still in women, the most common overall is indirect inguinal hernia. So don't get confused. Most common cause of urinary retention after hernia repair is general anesthesia. Most common injured nerve in open inguinal repair is the ilioinguinal nerve. And most commonly injured nerve in laparoscopic inguinal repair is the lateral femoral cutaneous nerve. So you have these triangle of doom, triangle of pain, and circle of death. Triangle of doom and pain. Remember, both share the gonadal vessels as their border. For triangle of doom, it's in the lateral portion. For the triangle of pain, it's in the superomedial portion. Right? So the triangle of doom, medially, it's bounded by the ductus deferens. As you can see this illustration right there. Posteriorly, it's the peritoneal edge. For the triangle of pain, it's the iliopubic tract inferolaterally and the reflected peritoneum laterally. Okay. So it's a triangle of doom because aside of having the femoral nerves and the genital branch of the genital femoral nerve, you have your external iliac artery and vein and the deep circumflex iliac and vein, which can cause significant bleeding or significant morbidity if it has been ligated or injured. Right? The triangle of pain is associated only with nerves. Remember, it's the lateral femoral cutaneous nerve, femoral branch of the genitofemoral nerve. It's the femoral branch, right, of the genitofemoral nerve because the genital branch of the genitofemoral nerve is found in triangle of doom. So basta it has femoral in its word, it's found in triangle of pain. But remember also your femoral nerve is found in triangle of doom also, and the genital branch of the genitofemoral nerve is in triangle of doom also. Again, lateral femoral cutaneous, femoral nerve in the femoral branch of the genitofemoral nerve. For the circle of death, you have the anastomosing vessels, common iliac, internal iliac, obturator, inferior, epigastric, external iliac arteries. So this is your circle of death or corona mortis. And just remember and familiarize yourself with this. The most common malignant tumor of the brain is, the most common malignant tumor of the brain is your, astrocytoma, letter B. Okay, most common malignant tumor of the brain is your astrocytoma. So your astrocytoma, again, are the most common primary central nervous system neoplasm, otherwise known as gliomas. They're rated 1 to 4 according to WHO. 1 is pilocytic. Pilocytic is 1. 2 is diffuse, low grade. 3 is anaplastic. And 4 is glioblastoma multiforme. So the most common type of astrocytoma is actually the stage 4 or the glioblastoma multiforme. So most common type of intracranial tumor is the cerebral metastasis. Again, same as your liver, most common hepatic tumor or malignancy is your metastasis. For brain, it's the same, cerebral metastasis. Most common primary CNS neoplasm, it's your astrocytoma, otherwise known as your glioma. Most common malignant pediatric brain tumor, it's your medulloblastoma, medulloblastoma near the brainstem, pediatric. Most common extradural spine tumor, they're metastatic. Most common intramedullary spine tumor, ependymoma in adults, and astrocytoma in children. Again, most common intramedullary tumor, ependymoma in adults, and astrocytoma in children. So that's all for April's lecture. I really wish you good health. I wish you'll be safe. And I wish you'll succeed in every goal you have in life. All I ever ask is for you guys to succeed, and I'm happy that my students will be able to reach new heights, and I think that's very satisfactory for me. So without further ado, you guys take care.